Dr. Raji.
Okay, we can start the videos now. Good morning, friends. I am Dr. Vikrant Desai, the Program Committee Chairman of Association of Medical Consultants, Mumbai. I welcome you all to this half-day seminar of COVID 2.0, which is the second part. The first part of COVID update was done in last May. Riding on the third wave, we have come up with another update program. Today, we have with us many expert, eminent speakers and panelists from COVID Task Force, ICMR, community medicine, consumer activists, Rotary Club, infectious disease specialists, and many more for bringing the updates and clearing any doubts regarding COVID and to discuss about future of the pandemic. Without wasting much time, I would now introduce Professor Dr. Sushmita Bhatnagar, the President of Association of Medical Consultants, Mumbai. She is the honorary consultant pediatric surgeon in Bombay Hospital, Global Hospital, ACI, Kambala Hill Hospital, and Apollo Hospital, Mumbai. She is a chairperson elect and immediate past chairman of Association of Pediatric Surgical Oncology. She is director of Focus, that is Foundation of Children's Universal Support. She is also an editor of Journal of Neonatal Surgery. She has about 100 publications and journals and chapters in books. She has also won multiple awards nationally and internationally. Welcome, madam. Over to you.
Thank you. One second. Yes, thank you and wish you all a very, very good morning. Good morning to our esteemed speakers, respected seniors, and our dear colleagues. As you have seen the videos which we had displayed, AMC, Association of Medical Consultants, is in its golden year. And each morning is a golden morning. It brings a lot of golden opportunities. Today, we have the golden opportunity to be all together on this platform and hear the golden words of our esteemed speakers. They will not only update us with the latest about the COVID and its variants, but also resolve many queries that we have in our minds. We wish that we could organize this seminar in an offline mode, which would probably be much better networking and understanding. But nevertheless, our work goes on and our commitment goes on. AMC from 1972 to today has, as has already been depicted in the short video which we had shown when we opened this webinar, it is an association with the mission and commitment. And this webinar today is with the same vision of fulfilling our mission and commitment to not just the medical professionals, but also to the people of this country. COVID has affected many lives. I'm sure all of y'all also have been affected, not just those who have lost their lives, but for those who have survived as well and have borne the brunt in some way or the other. Is there any life untouched, be it the first wave or the second wave? Personally, for me too, I lost my mother in the first wave and few dear friends in the second. And now we are seeing the third wave, which is much milder, which is receding, but there is still a lot which remains mysterious and unanswered. So let's hear it from our stalwarts and be enriched with knowledge and their wisdom. Over to you, Dr. Vikrant.
Yeah, thank you, madam. Now I would like to introduce our first speaker for the day, Dr. Rahul Pandit. He is Director Intensive Care at Fortis Hospital. He is Professor Emeritus of D.Y. Patil University, Kolhapur. He is visiting consultant at Bathurst Hospital and Vaga Hospital, Australia. He is member of the National Task Force appointed by the Supreme Court and member of Maharashtra Government Task Force for COVID-19. He is teacher for College of Intensive Care Medicine, Australia and ISCCM Fellowship and Diploma courses. He has got several original publications, book chapters, lectures, and scientific presentations. He has special interest in critical care, echocardiography, ultrasound, brain trauma, and organ donation. He has done his MD anesthesia from JJ Hospital. He has got prestigious fellowships of Australian College of Intensive Care Medicine and worked as a consultant in Australia for several years. He has European Diploma in Intensive Care Medicine. He has been recognized for contributions by the American College of Chest Physicians and confirmed. Over to you, sir.
Thank you very much, Professor Bhatnagar and Dr. Desai. It is indeed an honor to be here with the golden year of Association of Medical Consultants of Mumbai and Maharashtra. And yes, I indeed agree that COVID has been a very, very harsh reality for last 2 years. And no matter what we do, this virus seems to be predictably unpredictable, as some of my colleagues always call it. And I think we need to keep on just improving our skills and knowledge about it. And that seems to be a never-ending story. So I've been given the task to talk about practical approach towards management of its disease. So are my slides visible, sir?
Yes, sir.
Thank you. All right. So, you know, the world meter of COVID-19 cases just keeps on clocking up. And as days go by, we are seeing more number of deaths. Fortunately, the recoveries have been more than the deaths. That's been the only saving grace in this last 3 months or so. Since November, the cases started going up in the world again. And in fact, there was a time between 22nd December to 28th December that we were almost having 900,000 cases in the world every single day. That's a large number of patients, you know, that's a huge number of patients. And we thought that Omicron is mild, but we knew that it is probably dodging the immunity which was given to us by the disease or by the vaccination which we went through. Unfortunately, the mutations happened at the spike protein itself. And those mutations were almost to the count of 30. There were overall around 50 mutations in this Omicron, and there were almost 30 mutations in the spike protein. And they were around 10 on the receptor binding domain. And that's why people who had previous infection or people who had vaccination completed, even booster dose been given to them, the immunity was not good enough to be actually saving them from getting infected. However, what we realized is that the immunity was good to save us from severe disease or moderate disease. So not many patients landed up in the ICUs and the hospitals. Most of them remained confined to the home and home quarantine. A few required admission, I'm not denying that. And obviously there was a mix of patients who were having Omicron, which was the majority, followed by patients who were having some amount of Delta and Delta derivatives, which were still floating around into the community. One of the things which Omicron did was it actually replaced Delta very, very quickly without even realizing. Almost 80 to 90% of the cases became Omicron within a span of 2 weeks. Another problem which happened with this mutation was that we started to realize that are we having a good enough robust diagnostic system to diagnose this new variant? Fortunately, that was not the problem. However, with the S protein or the S gene dropout, which we talk about the S gene target failure, there were a lot of confusion about proxy use of this S gene to diagnose Omicron. And I think that's where we probably should have been a little bit more cautious. Many labs started giving out S gene dropout. I myself was convinced that S gene dropout seems to be the way to go ahead, because that was giving you a differentiation whether it is Omicron or Delta. But then as we started to know more about things, we started to realize that S gene dropout wasn't the holy grail. And very soon, the virus showed its true color. And we had the BA1, BA2, and BA3, three sublineages of Omicron come in, where the BA2, which seems to be quite predominant in the Indian subcontinent, actually does not have a S gene dropout. And that is something which was very, very important for us to know, because one of the things which parallelly started, and I'm going to cover up that in my talk, one of the things which parallelly started up with this was the use of monoclonal antibody. And a lot of people actually started using monoclonal antibody, which was a big concern. So if you look at the classification of patients, we classify them based on the Ministry of Health and Family Welfare, Government of India, as well as the Maharashtra Government COVID Task Force definition into three categories: mild, moderate, and severe. Mild or asymptomatic being limited to upper respiratory tract, asymptomatic obviously no symptoms at all, and symptoms without shortness of breath or any evidence of hypoxia. A moderate patient is one in whom the respiratory rate goes above 24 per minute, and the saturation still remains above 93-94%. And severe disease, where you have a respiratory rate which is higher than 30 and your drop of saturation is more than 90% on room air. I'm going to have a very practical approach. That's what the topic was given to me, to talk about practical approach. I've not gone too much into the evidence of that, but I will keep on talking about the evidence as we go into the talk. So most asymptomatic and mild patients just require to be reassured, because there is a lot of panic amongst them as to what is going to happen. Especially this S gene dropout or S gene target failure has created another question in their mind, that should they be going and taking the monoclonal antibody. Hundreds and thousands of calls each day just to make sure that the patients are actually comfortable is what was going on in the last week of December, first 2 weeks of January. And all of them had one question: should I take monoclonal antibody? Is it necessary for me to take monoclonal antibody? So most patients in home isolation, they just need to be reassured. They should be just given symptomatic treatment, antipyretics, hydration, antitussives if they had a bad cough, or inhaled budesonide, which is one of the best proven therapies in patients who have persistent cough beyond 4 or 5 days of their disease onset. Multivitamins were given, unfortunately. However, I would be very, very clear that there is no need to give any multivitamins, whether it is zinc or vitamin C or vitamin D. If you were deficient in vitamin D, by all means, go ahead and give vitamin D. But otherwise, absolutely no need to give hypervitaminosis to each patient. What needed to be done was they had to be given clear instructions as to when to present to a hospital or seek immediate medical attention. And this is the most important thing, which was done very, very nicely in this third wave, that many patients who, despite staying home, stayed in touch with at least one healthcare practitioner. And they were told to come to a hospital if they had severe cough, high-grade fever, which was lasting for more than 4 or 5 days, or a 6-minute walk test showing a drop in the saturation. In patients who were having high risk for disease severity, the special care had to be taken, and those were patients who were elderly, who had either a heart disease, diabetes, immunocompromised state, chronic kidney disease or liver disease, and of course cerebrovascular accidents or obesity. I think these were the individuals who probably seek more help in the hospitals and wanted to be in the process of getting admitted. Reasons were obvious, that they were worried for themselves. The next category is the moderate disease. What do we do? Once they have reached to a point where their saturation is hovering in the low 90s, they need to be admitted into the ward. One of the best things which has happened is you actually keep them awake prone. The awake proning has been one of the magical therapies which we have sort of started to use quite extensively since the onset of second wave. And that was something based on the trials done in intensive care unit, where we were proning these patients with severe ARDS and finding that the results were miraculously better. Their outcome in terms of mortality also improved. We have correlated and extrapolated that data now to awake proning. And awake proning, we see that the CARP protocol, or the sequential proning for every 2 hours or so, changes the oxygen saturation dramatically and seems to help the patients in recovery process. Obviously, you need to keep their saturation only around 92% to 94%. You don't need to target 100% oxygen. The rational use of oxygen has been clearly described in the second wave for us. In patients who are in monitored environment or patients who have got chronic respiratory diseases, you could lower down the target to 88%. Obviously, when you're lowering the target to 88%, they need to be in a monitored environment, preferably in a high dependency unit or so. And the preferred devices for oxygen were either HFNO or non-rebreathing mask. Once you are hypoxic, the only trial, the recovery trial, which actually showed a positive result and till date has been the cornerstone of therapy in patients who are hypoxic, has been low-dose steroids. Low-dose steroids in the dose of 6 milligrams of dexamethasone or equivalent of methylprednisolone, usually given for a day for a duration of 5 to 10 days. I think that's very important. Low-dose methylprednisolone or dexamethasone limited to 5 to 10 days therapy only. We should not be switching on to therapies beyond 10 days at any cost. If the patient gets better within the first 3 to 4 days, you can switch to oral steroid and stop the steroid within the 5 to 10 days period. Anticoagulation. A lot of hype was created about anticoagulation based on D-dimer. I think this D-dimer based anticoagulation therapy is obsolete and did not be followed at all. We need to understand that anticoagulation is not something which is required for patients who are asymptomatic or mild. In patients who are admitted in the ward, a DVT dose prophylaxis of enoxaparin, usually between 40 milligrams to 60 milligrams subcutaneously once a day, is more than enough. And there should obviously be no contraindication for bleeding in these patients. Otherwise, in intensive care unit patients, which I'm going to come, anticoagulation should be given to all patients unless contraindicated in form of DVT prophylaxis again. In patients who have multisystemic organ failure, who are on ventilator with multiple supports, one may choose to give a full anticoagulation in form of 1 milligram per kilogram subcutaneously twice a day of enoxaparin or any other low molecular weight heparin, so that these patients have at least a period of time where they are fully anticoagulated, and they should be rapidly brought down to DVT prophylaxis dose as soon as the patients get better. Another thing which happened in the second wave and which thankfully has been a complete change in the third wave is monitoring. Clinical monitoring has taken the precedence. People are more asking about clinical parameters like saturation, heart rate, blood pressure, rather than actually rushing for CT scans and serial X-rays. I think that one thing has definitely changed in this third wave. People are not rushing for CTs, for HRCTs. And the reason is obviously that this wave has been confined to the upper respiratory tract. Even laboratory measures like CRP, D-dimers, complete blood count, kidney function test, liver function test have only been limited to patients who were admitted. And obviously IL-6 and CRP should be done only in patients who are deteriorating. Otherwise, there is no role to do it in a routine way. Once they progress on to have severe disease, we need to obviously admit them in a monitored environment wherein they're in ICU. The respiratory support would obviously depend on the amount of oxygenation failure or ARDS which they have. And that is PF ratio is what we talk about. And the PF ratio is something which we determine whether the patient is going to maintain on a high flow nasal cannula. High flow nasal cannula seems to be the way to go forward because you can actually prone these patients quite well on high flow nasal cannula. There is a considerable amount of patients who probably require non-invasive ventilation. But I think the message, which again I'm going to be very, very clear about, is that we should be intubating these patients in priority if they have high work of breathing or if HFNO or NIV is not working on them. And that's why just by putting somebody on high flow nasal cannula, we should not be forgetting to keep them monitored and reassessed every so often so that we can address this issue whether this patient requires to be on a mechanical ventilation or not. Once they are on a mechanical ventilation, you use the conventional ARDSNet protocol for ventilatory management along with prone position for them. 16 hours of prone on ventilator with a patient who is completely sedated and paralyzed for at least first 2 to 3 days is something which we should be doing. And the ARDSNet protocol is very clear. 6 ml per kilo body weight of tidal volume, along with plateau pressures less than 30 centimeters of water, the respiratory rate varying between with the respiratory rate maximum of around 35 and a tolerance of a little bit of CO2 going up is fine. Try and maintain a PF ratio around 150 to 200. If the PF ratio is below 150 consistently, you need to keep on proning these patients. Obviously, some of them may require to go across and get some high-end therapies like ECMO, but those numbers are short. Again, anti-inflammatory immunomodulatory drugs, I would again say low dose methylprednisolone and low dose steroids is in form of dexamethasone is what we should be giving. Anticoagulation, there is no change or recommendation in anticoagulation except the category where they are in multi-organ failure. You may want to use a high dose of anticoagulation in form of full anticoagulation to 1 milligram per kilogram twice a day to be given morning and evening. We try and maintain these patients euvolemic or slightly on the drier side. We use dynamic measures to assess fluid responsiveness. What is a dynamic measure? Just a CVP is not going to help. So we usually put in some monitoring devices like an arterial line. We look at stroke volume variation or pulse pressure variation based on the arterial line. We also use ultrasound in form of echocardiography to do an IVC assessment. We do a passive fluid leg raising test and see whether these patients need to be given some fluid or not. If they have fluid requirement, it is given in small allocates rather than in large boluses, and that's the way we actually try and maintain them euvolemic. If you flood them too much with fluids, you will usually find that these patients become more and more hypoxic because the fluid tends to sweep into the lungs and form more amount of problems than any good for these patients. If they have gone into septic shock, I usually ask my colleagues to refer to the surviving sepsis guidelines, which means that you need to culture them, a pan culture from head to toe of the problems which we may be thinking are causing the sepsis, whether it is the line, whether it is the lungs, whether it is the urinary tract. So a syndromic approach is required, and accordingly, antibiotics can be started. Do not give prophylactic antibiotics just because these patients are having a central line or a Foley's catheter or are on a ventilator. You need to give appropriate antibiotics thinking on the syndromic approach from where the sepsis or the septic shock may be originating. Again, patients who are in ICU on a ventilator would require serial X-rays, but a HRCT should only be done if there is going to be a change in the treatment, which means that you only do it when the patient has significantly worsened. Many times, practically what we find is that these patients are so hypoxic that we actually don't need to do a CT scan because they're just not able to be transported down to a CT scan. So I usually like to do the blood, at least CRP and CBC every day, and a liver function test and a kidney function test can be done once in a while. Now let's come to some of the therapies which have been given an emergency use approval and have had reasonable evidence tried to be generated, but they still remain only in special circumstances drugs. So remdesivir, I think there has been enough studied about this. We need to understand that remdesivir needs to be given in the viremia phase. It is being talked to be given for patients who are requiring supplemental oxygen. And there is a new trial which has come out, the Pine Tree trial, which basically looked at giving a short course of 3 days remdesivir to be given over patients who are from the OPD. I think it might be difficult for this strategy to be implemented in our country as an OPD basis remdesivir, but certainly patients who are admitted, that means who are moderate, you should be giving them remdesivir as quickly as possible. Do not wait for them to deteriorate requiring high amount of supplemental oxygen. If you're admitting them, start them with remdesivir. We need to monitor their hepatic and renal function. We need to obviously give that in the first 7 to 10 days where the viremia is there, and it should not be used in patients who are on very high ventilatory settings and they've straight away come to the hospital on a ventilator. It's probably not going to make any difference to them. Now, tocilizumab, I have personally not used tocilizumab since September 2020, but I'm by no means saying that you should not be using it. I think you need to meet all the criteria which are given here. Presence of severe disease, preferably within 24 to 48 hours of severity of onset of severity or ICU admission, a significantly raised CRP and or IL-6 if you do an IL-6. Despite starting steroids, these patients have not shown an improvement. There is a reasonable effort being put in to rule out bacterial, fungal, and tubercular infection. And the recommended dose is a single dose of around 400 milligrams to be given in 100 ml of saline over 1 hour. There is no need to repeat any more tocilizumab. I can tell you that even in the hospitals which were using tocilizumab, the third wave has really not seen many of them being used. This is a very famous slide which has been there for a long time, which talks about the disease progression and the various inflammatory processes. I'm not going to go through that, but we need to understand that in the first phase, when there is viral replication, and in the initial second phase, you may be using antivirals. You will probably see the deterioration happening in the second phase and as they go into the third phase. And that's been the variant of the Delta, which has sort of behaved that way. Omicron probably behaves in some individuals, at least in those who have got immunosuppressed therapy in a similar way, but not all of them. I think that's where we need to understand. We need to understand the disease process. Another thing which has happened is that initially when the first wave started, we were thinking that the entire process of COVID is of around 14 days. Delta changed that perspective. Now we know that these 3 stages could pan over at least 3 weeks, if not more. And we have seen patients deteriorating on day 15, day 16, day 17 in the third week as well. Omicron again has changed it back. We probably are now, okay, most of the patients with Omicron become a non-infective by between day 7 and day 10, and they usually don't progress beyond that. However, we need to remember that there is still some Delta and Delta derivatives in the community. I think I'm going to skip this because that's not really a part of the thing. I'm just going to quickly go into the symptomology of Omicron variant. So some of the things which have been very, very clear is there is significant amount of tiredness, cough, headache. There is that should be no loss of taste and smell. My apologies. That's not the way it should have been typed. Congestion or a runny nose. Some patients do have some GI COVID, which is nausea and vomiting. So the preservation of loss of taste and smell is something which is differentiating Omicron from Delta. In Delta, we saw a lot of patients lose their sense of taste and smell. I'm going to come to some of the therapeutic agents which have been used. Just last few slides. Symptomatic management, obviously, we talked about. Antipyretics seems to be the way to go. Analgesics in a patient who has got severe throat pain or very severe body ache. A combination of single dose of non-steroidal with antipyretics is probably okay. Monoclonal antibodies, there are 3 monoclonal antibodies. The casirivimab plus indivimab, which is available with us. The bamlanivimab plus eslivimab, which is not available. And soltrovimab, which is the new antibody, which is working against all variants, is also coming into market shortly, is what I have been informed. Steroids we've already talked about. Other agents like azithromycin, doxycycline, colchicine, fluoxamine, vitamin C, vitamin D, and zinc should be thrown into a waste paper basket as far as the COVID-19 management goes. Anticoagulations, again, should not be initiated in OPD settings and only should be done in patients who are admitted, otherwise not. So let's come up to some of these monoclonal antibodies. The one which is available is casirivimab and indivimab. It has got an emergency use approval for patients who are at least 12 years of age, more than 40 kilos. Its mode of action is essentially that it targets specifically the spike protein and it blocks the virus attachment and entry to the ACE2 receptors. The dose is 1200 milligrams, which is 600 milligrams of each drug, which is administered intravenously or subcutaneously, and can be administered within first few days of patient testing positive. Earlier the better, but it has got a caveat. Two caveats here. One, you need to have a patient to at least have one of these comorbidities. That means they should be elderly, obese, cardiovascular disease, or lung disease, or type 1, type 2 diabetes, chronic kidney disease, immunosuppressant, thalassemia major, or they have some form of a cancer or a immunosuppressive therapy. The second problem, which is come up specifically in third wave, is that if they are Omicron, then this drug is not going to act on the Omicron because it has got the mechanism of entry into the spike protein itself, and that spike protein entry does not have the immune system right now available with this monoclonal antibody to be effective enough. This antibody, which is again, I'm going to skip out, it's again active against only the Delta variant, unlikely to be active against the Omicron. Whereas this antibody, the sotrovimab, which will hopefully be available to us, it is available in the world right now, does act against Omicron as well. Again, it is probably something which should be given early on in the disease. The criteria or the eligibility population is almost same as casirivimab and indivimab, and it should be recommended within the first few days of onset of therapy, provided it does become available. Few new drugs and few old drugs I want to cover up. Just last few slides. Mechanism of action of molnupiravir. Molnupiravir came up with a lot of hype, and Paxlovid, which is the other Pfizer drug, which has not yet been launched, and it sort of came up with a trial that there is a 30% reduction in hospitalization and death. It got an emergency use authorization to be used in confirmed mild or moderate COVID-19 patients. The eligible population was adult at high risk of progressing severe COVID-19 disease. However, it came for a lot of flake because of the complications which it had. And what are those complications? It has got complications of stalling the growth of children below 18 years of age, especially the cartilage and bone growth. It has got some teratogenicity in the reproductive age group. Hence, these drugs should not be used for patients who are below 50 years of age. That means their active reproductive age is there, or they are below 18 years of age. So molnupiravir essentially gets thrown out of the window for majority of the patients. And then whom would you use? Would you use it in any patients? I would probably use it in a very small subset of patients, which is patients who are above 60 years of age, in whom there is at least one or two comorbidities which are clearly seen. And despite standard supportive care with antipyretics, their symptoms keep on worsening for the first 2 or 3 days, or they have a fever which is not touching the baseline, or in fact is very, very high for the first 2 or 3 days. I would then like to start molnupiravir within the first 48 to 72 hours. So if it is gone more than 5 days from onset of symptoms, I think molnupiravir is of no use. Again, I would be very, very clear. Should not be used in pregnant ladies, should not be used in lactating women, should not be used in active reproductive age group. That means people up to 60 is gone. Should not be used in children below 18 years of age. May be used. And if these patients above 60 are going to get admitted in the hospital, I would use a small short course of remdesivir instead of molnupiravir. But molnupiravir has that little limitation in that subgroup where you can use that. I think favipiravir, which we actually used quite extensively in the second wave, is almost out. The data for favipiravir is even weaker than molnupiravir. Unfortunately, despite millions and millions of patients receiving favipiravir in the second wave, the data for favipiravir was not done in an active way. The only trial which we have is the one which was done by our senior colleague, Dr. Zahir Udwadia and his team, which was when the favipiravir actually got the emergency use authorization. Since then, there has been no further trials which have actually gone in favor of favipiravir. If you look at antiviral activity of the three antiviral drugs available, remdesivir in vitro activity to a concentration of EC50, favipiravir and molnupiravir, probably you can see that that favipiravir does not have a lot of activity present as such. I would like to summarize that there is still a growing concern of variants coming across, and there may be a need for newer and newer therapies. I think corticosteroids remain and belong to some of the commonly prescribed drugs for hypoxic COVID-19 patients. Apart from that, it's all supportive therapy. Remdesivir and molnupiravir have proven to be efficacious in clinical trials. However, there needs to be a restricted prescription in individual cases, especially of molnupiravir. And I think the treatment guidelines recommend the use of monoclonal antibodies in non-Omicron variant only, not in any other variant, provided the patient fits into the description what we talked about. With that, I would like to stop sharing, and I'll be happy to answer any questions if there are.
Yes, sir, there are actually two questions in the chat box. One is by Dr. Subhash Patel. He's asking, FDA in US has removed monoclonal antibody for Omicron. Then why should mRNA vaccine that produce antibody against spike protein only be effective?
So FDA has removed monoclonal antibody for Omicron because Omicron, you should not be giving, it is not effective. They have not banned monoclonal antibody from Delta. In Delta patient, it can still be used provided they are high risk. Now, should mRNA vaccine that produces antibody against spike protein only be effective? Well, we found that it has not stopped people from getting infected, and that is why the entire world is actually giving booster after booster. So if you look at UK and US, they are giving one booster dose. Israel has gone across and given the fourth dose as well. So mRNA vaccine, or whether it is our AstraZeneca vaccine or Covaxin, all of them which have targeted spike protein as the main point to block this virus from getting infected, have not really gone across and given us a sterilizing immunity. The only hope, which I may be wrong, but listening to some of my friends across the world and reading the literature, the only hope is for a mucosal immunity, which probably is going to come from a nasal vaccine. If a nasal vaccine comes, we may have some sterilizing immunity, which will prevent the infection. So that sterilizing immunity will probably be the saving grace if at all the vaccine trials actually prove out to be good. So we should not speculate. We should wait for the data to come out in open. And we all know how vaccine manufacturers have, some of them have been very proactive and given out their data in open journal. Some of them have only given it out after several months of emergency use authorization. So I think the data which is available in open access is what we should be looking at, not something which we don't hear and don't know about.
Thank you, Dr. Rahul Pandit, sir, for a very informative and an excellent lecture. Please accept this certificate and memento as a token of appreciation from Association of Medical Consultants, Mumbai.
Thank you. Thank you very much, Dr. Desai. Thank you.
This is the certificate and the memento. Thank you so much once again, sir. We are very happy to have you here.
Thank you from all of us from AMC, because I know that you had been extremely tied up with some few other things, but because of AMC and because of us, you have accepted to be on our panel today. Thank you so much.
Thank you, madam. Thank you. It's a pleasure and honor.
Yes.
Would it be okay if I log out?
Yes, sir. Yes, sir. I know you have your family commitment.
Thank you.
Thank you, sir.
Thank you.
For being
Thank you. Have a good day. Thank you all.
You too, sir. You too. Now, I would request our Vice President of AMC, Dr. Rajiv Agarwal, to take the program forward. Over to you, sir.
Good morning, everyone. A warm welcome to all. Let me introduce the next speaker, Dr. Suhas Prabhu. He is a visiting consultant and professor of pediatrics, DNB, Hinduja Hospitals, Mumbai, accredited teacher in pediatrics for 37 years, special interest in infectious disease and immunization, visiting fellow at MGH Boston and Children's Hospital, New Orleans, more than 50 publications in national and international journals, contributor to textbooks of IAP on infectious disease and other topics, assistant editor of the Pediatric Clinics of India for almost 7 years, section editor for Pediatric Infectious Disease Journal, convener RPSRID GEM and chairperson Rational Antibiotic Therapy and War Gems of IAP, co-chairman National Task Force on Guidelines for Rational Antibiotic Therapy in Pediatrics, chairman National Task for Pediatrics COVID-19 appointed by Government of Maharashtra. He is an expert speaker, a good person, and a very good doctor par excellence. Over to you, Suhas Prabhu, sir.
Thank you for that kind introduction. And my thanks to the Association of Medical Consultants. I think this is an excellent organization. I'm happy to be a member of this for more than 3 decades. Although I can't say I've been there from its inception, and I congratulate AMC for completing 50 years. I'm also very happy to have heard Rahul Pandit speak because he has cleared the decks for my talk. I am not going to have to talk much about what this virus actually does to the body, and I can concentrate on the action points in pediatric COVID insofar as they differ from the adults. So let me just start. Are my slides seen?
Yes, sir. Yes, sir.
Yes, sir. Yes, sir.
Okay. Now, there is a slight difference in the SARS-CoV-2 infection in children compared to adults. First is the fact that you get 2 different types of diseases. You get an acute COVID illness, which is very similar to what Dr. Rahul Pandit described in adults with the 3 phases. However, in the highest number of them, over 90 or 95% have a very mild course with a quick and complete recovery. But you also see in children a special condition which you don't generally see in adults called the multisystem inflammatory syndrome, which can occur a few weeks to a few months after an acute COVID illness. And this COVID illness might have been mild enough to go even unnoticed. So the child comes directly presenting with an MISC. And you can also see this in newborn whose mothers have had COVID. As I just mentioned, the majority, 90 to 95%, have asymptomatic or mild illness. Moderate illness, which Dr. Pandit has already described for you, is seen in 5%, and severe pneumonia or MISC constitute only 1 to 2%. And these are the only ones that require treatment in a special COVID care PICU or high dependency unit. These 5%, of course, will need to be managed in a hospital, a pediatric COVID care center, whereas the rest can be managed at home. And that's what we've been practicing all through. The difference between, Dr. Rahul Pandit mentioned that in the 3rd wave, majority of adults also have been either asymptomatic or mild. But in children, this has been the case right from the 1st wave. And all we need to do is to follow them at home with possibly a daily teleconsultation with the pediatrician. Now, the difference between adults and children is the fact that while an adult may get fever with sore throat and body ache and symptoms suggestive of COVID-19, you would think more or less that, yes, this is likely to be COVID-19. Children, unfortunately, can have fever due to so many other causes. They can have recurrent simple viral infections, and they have several other causes of fever that you see in children, like dengue and malaria, GI tract infections, urinary tract infections, all of which can present primarily with fever as the main symptom. So the child will present to the doctor as a case of fever. And the first question you need to think is whether this is COVID or a non-COVID illness. And of course, the very vital question is whether testing for COVID is required. If COVID is likely or proven, of course, you need to do the triage, which I've already described, severe, moderate, or mild case, and treat the patient accordingly. And the primary doctor, the primary clinic doctor, role doesn't end here if it's a mild case. If it's a mild case, he has to be the person in charge to do the home management. And this is, of course, the child is never called back unless he deteriorates, because that would be a super spreader event if he keeps coming to the doctor's clinic. The follow-up is done on telephone, teleconsultation. So let me run through you what happens in a pediatrician's mind when a child comes with history of fever for 2 days. The first question asked is, could it be COVID? But as I said, the symptoms of COVID-19 can mimic many other viral illnesses. So you need to go through this process of trying to find out what the symptoms are like, how the child is between the interfebrile period, and any associated symptoms that might point to an infection in some other system. Very vital, of course, is history of contact with COVID. We also need to ask for previous history of fever. This is from the point of view of MISC. And of course, like in adults, we look for comorbidities. But also very important, when you're talking about home treatment, the family and housing details are also important. I'll come to that in an actual case. You can, of course, should do a COVID test for all cases. However, we know that resources may be scarce. And you may defer testing in children who have very mild symptoms and no comorbidities, especially when you have a known positive contact. Like you have parents who are testing positive and the child has similar symptoms. I think it's a waste of resources and money to try and test the child. You would assume that it is mostly COVID-19. This is the probable COVID that we talk about. But if you have done the test, whether it's an RAT or a RT-PCR, you will then label the child as a definite COVID. So if you look at this particular child, and this one example I'm talking about, we know the father has been in home isolation for 5 days for COVID. The mother is asymptomatic, but since this is an infant, 13-month-old, she's breastfeeding, you have to ask for the family history. And you find that there is an older brother, father, and a 67-year-old grandmother who live in a 2-room apartment with a common toilet. We know that this is a probable or confirmed. You'll say it's confirmed if you've done the test. And we're going to say this is mild if these 3 main features are not there: fast breathing, which would suggest a lower respiratory tract involvement, lethargy, somnolence, or seizures, or the presence of dehydration, which would require hospitalization for intravenous fluids. Now, Dr. Rahul Pandit mentioned a cutoff at 24 per minute as a sign of fast breathing. It's not really valid in children because the respiratory rates are normally higher. So we have cutoff rates for various age groups here. But what is the next step? The next step is, of course, to check for the comorbidities, which are listed here, which are similar to those in adults. If they are present, then, and if there's no ready access to healthcare, then might be better to admit for observation. But if there is ready access to healthcare and the reliable attendants are there, the parents are smart, they are capable of looking at signs and deterioration, then you can continue as per mild disease at home. And if these are not there, then of course we will do home care. So what is this home care? Is quarantine for 7 days, separation, isolation from the grandparents, which we described in this patient. There's a grandmother here. Other family members are not affected should wear a mask when in the vicinity. There's no change in the diet. Breastfeeding can be continued. Older children can be asked to do saline gargles. But very important, as Dr. Rahul Pandit has already emphasized, symptomatic treatment is the key, no antibiotics. And for these patients who are at home, who don't even require hospitalization, no investigation, not even a CBC or CRP is required, but you need home monitoring by a parent, or in rural areas where parents may not be smart. We have recommended as the task force to the government that an Anganwadi or any other worker, paramedical worker, can do this monitoring. What do you monitor? You monitor these 5 parameters, and they can be done at home, but not just monitor, you need to keep a chart. So these 5 monitors have to be, parameters have to be monitored, and they have to be reported daily to the doctor or to the Anganwadi worker. The patient can maintain such a chart, which can be given to the patient in vernacular. These are the 5 parameters: temperature, pulse, respiratory rate, SpO2, urine output, and any other symptoms. These are the cutoff respiratory rates that I mentioned. These are the red flag signs where the person has to now go to the pediatric COVID care hospital, and they can be filled in by the parent. So this is what we are proposing, and the red flag signs, and this is what has been done. This is how we have successfully managed children who have mainly mild symptoms in all the 3 waves so far. The red flag signs are listed here again. These are the same ones, but you see these additional ones here: rash, red eyes, and red lips, which are symptoms suggestive of MIS-C. And that will require a special care, which I will talk about a little later. And if our child has these symptoms, then yes, you will send the child to a pediatric care hospital if he's already been definitely diagnosed as a COVID case by an RAT or RT-PCR. If that is not done, you're going to do this and keep the child in the holding area till then. And if it is the rapid antigen test or RT-PCR is negative, you're going to look for non-COVID causes. Now, the treatment of COVID care in children is very simple. Dr. Pandit has already told you that the main antiviral drugs like molnupiravir or even favipiravir and the monoclonal antibodies are not recommended in children at all. So it's primarily symptomatic. Antipyretics are the mainstay for the mild cases. For the moderate cases, steroids, as he rightly said, are the first drug of treatment. You can opt for metered dose inhaler Budecort therapy with some possible efficacy in children who are mild to moderate at home. Antimicrobials only if there's bacterial infection, and of course, management of the comorbidities. Awake proning is important. Oxygen is important once the saturation drops. Steroids are the mainstay of therapy for these children who are hypoxic. Remdesivir is only recommended if the oxygen requirement is increasing. And this, remember, is an off-label compassionate use because it's not really recommended in children and it's contraindicated with hepatic or renal dysfunction. I'm not going to go into the detailed management of severe COVID. Dr. Rahul Pandit has covered it exceedingly well. But essentially, it's monitoring with these parameters, optimizing the oxygen, as he mentioned. These are the recommended methods of giving oxygen. Invasive ventilation is the last resort, but might be proactive if your patient is tiring. Prone positioning is important. Restrictive fluid therapy is important. And here we have this plus minus because they're not really recommended in children. And of course, management of the complications. Now, what about a newborn? Can newborn get COVID? Yes, it can occur if the mother got infected just before delivery, but the incidence is very low. The newborn may show signs of COVID-19 at birth or soon after, but may be totally asymptomatic. But although asymptomatic, these infected newborns are silent carriers and they may shed the virus to infect others. So while the majority, as shown in this pie chart here, are asymptomatic or mild, they are still a risk to others, and therefore quarantine should be practiced for 1 to 2 weeks. A small minority will present with severe COVID, and another small minority will present with MIS-CN, which I will talk about later, and that can present up to 4 weeks of age. And therefore, the follow-up needs to be done. Delivery room preparedness, I will just run through this slide. It's just taking precautions to prevent infection to the personnel. And there's the standard guidelines about using PPE, avoiding crowding, using an exhaust fan, and so on. And this is the approach to a neonate born to a mother who's COVID positive. You must do an RT-PCR test in the child at 24 hours of age. And you need not repeat this if it's negative unless the child develops symptoms. If the mother is well, the child can be roomed in with the mother and breastfeeding can be allowed. The mother should, of course, wear a mask and practice hand hygiene. If the mother is sick, the child will have to be cared for in a relative. And if the relative is not there or the child is sick, you have to admit in a COVID care ward. But the child may still be fed express breast milk. This is the management of a COVID care patient. It's on similar lines as in the adults. It's basic respiratory support, IV fluid support. Antivirals are not recommended. Adjuvant therapy is not recommended, but you need to rule out sepsis, which might require antibiotics, because that can be a close differential diagnosis. Now, let me talk a little bit about MIS-C. This is an antibody-induced condition which can occur, as I said, several weeks to 2 or 3 months after a COVID infection. How do you think of this? You see symptoms like urticarial rash, non-purulent conjunctivitis, inflamed lips like you see here in this child, a BCG scar reactivation. The child is usually prostrated, irritable, GI symptoms are common, and of course this might resemble other conditions, so you need to rule them out. And a history of contact with the COVID or previous history of COVID will, of course, increase your suspicion. We have all types of MIS-C. It's not of one kind. Many of them just have mild symptoms. We call this a febrile inflammatory syndrome. We just need symptomatic management at home, sometimes low-dose steroid. A majority present, like I showed you in the previous slide, with symptoms that look like Kawasaki disease, and the treatment is similar with steroids and IVIG, low molecular weight heparin, followed by low-dose aspirin. This is because of the cardio-coronary involvement that you see, and a small minority present with shock and multi-organ dysfunction, which requires high-dose steroids and other treatment. A neonate will present very similarly up to 4 weeks, but they can also have very non-specific symptoms, low fever, or they may have nasal discharge, vomiting, breathing difficulty, and so on. But the treatment is essentially symptomatic, but we can give IVIG to these patients. This is what a neonate with MIS-C would look like, with the Kawasaki disease phenotype, with the typical rash at the extremities, the red eyes, and the cracked lips that you will see here. The management, as I just said, is symptomatic, IVIG and steroids. You might opt for antimicrobials if you're not sure there's infection, since you're giving steroids to this patient. The indication for low molecular heparin is only if you see a coronary aneurysm with a Z-score above 10. Now, I want to spend the last few minutes on vaccination of children and adolescents. Why do we need, since we are saying that children are not really affected so far, to a large extent? It is required to remove the reservoir of susceptible patients. Dr. Pandit already mentioned to you that in Africa, South Africa, the Omicron variant probably arose because of the low vaccination rate. Remember that when you have a reservoir of infection, there is a rapid multiplication of virus in these patients, and that gives the virus a chance to form a new mutation. So it's important to remove this reservoir, and that's why we need to vaccinate children, at least above the age of 12, if not above the age of 5. Also, that adolescents, especially if they have comorbidities or they are obese, they can have severe illness, like I said, almost like in adults. We know that we have a vaccine that has completed trials in children, and that's been found to be effective. And of all the vaccines available worldwide, Covaxin probably has the best safety profile. So you know that we have started vaccination in the age group 15 to 18 years, which hopefully will be extended to younger children and those with comorbidities, like has been done in several countries in the world, like the UK, US, and even third world countries like Ecuador. I want to spend a few minutes about school closure. You all know that we closed school closure. The schools were closed for almost 2 years now. What were the results? We did online teaching, but we know that it's not the same as classroom academics. It is not as effective, and children's academics has suffered. Many children without internet access or smartphone have lost out on this online education. We know that this isolation has resulted in emotional and psychological damage to many children. Their social skills have suffered. Children have got addicted to smartphones and sometimes food. I've seen children put on 10 kilos and 15 kilos in the last 2 years because they just sit at home and eat because there's nothing to do. We also know that children from lower socioeconomic strata and rural areas have suffered nutritionally because they have lost their midday meal, which was an important part of their nutrition for children from this strata of society. So we have said, the task force has said that schools and colleges to be reopened. I think you know that in Maharashtra, schools were reopened this week and colleges are reopening next week. Is it safe to do so now? And I'm going to put here reasons why we think it's safe. 2 years and 3 waves of COVID has shown that the disease of all variants is generally mild in children with low morbidity and mortality. The onset of the third wave with the then unknown quantity of Omicron elicited fear and reclosure of schools, but we know now after a month of data that this variant is a mild one, does not cause severe children or mortality in children, leave alone adults. The concern about children becoming super spreaders, infecting their parents and grandparents or other elderly contacts is misplaced, is overdone, and the danger is now much reduced since most of the adults have been vaccinated and those who are elderly and comorbid are even getting their precautionary dose now. So we think it's safe to reopen the education institutes. So I want to summarize what are the take-home messages. Children can get affected by SARS-CoV-2 and get acute COVID-like illness, but also a late complication, MIS-C. Presentation of acute COVID in children is like in adults, but is often milder. Antibody cocktails and antivirals are not routinely used in children. Supportive care, oxygen, steroids, and anticoagulants are the main drugs that we use for severe or moderate COVID. MIS-C can occur a few weeks to few months after infection and is treatable with steroids and intravenous immunoglobulin. Vaccination of children for SARS-CoV-2 is desirable and safe, and closure of schools and colleges for long plays havoc with education and is not desirable now, and therefore they are being opened. Thank you, and I will take questions.
Thank you, sir. Excellent talk. You have enlightened us about pediatric COVID. Just a few questions from the chat box and my personal questions also. What are the, sir, incidence of MIS-C in India, what you have seen? And what are the early warning signs where a pediatrician or a treating doctor can consider that the child is going in MIS-C?
Okay, very important question. I can tell you the number of MIS-C cases that we have seen, but the incidence is very difficult to tell you because the denominator cannot be defined.
Okay.
A large number of these patients have been asymptomatic. Some of them even deny that they ever had a COVID-like illness. So without knowing the denominator, it's very difficult to tell you what the actual incidence, because your question is out of 100 children who get SARS-CoV-2 infection, how many will get MIS-C? Very difficult to answer because the denominator is difficult to define, but it's probably very low. I would say it's between 1 and 2%. And again, unlike acute COVID infection, it is not dependent on comorbidities. So any child who's really healthy and otherwise well can still get MIS-C. So I think that answers the first part of your question. What was the second question? Second part?
The early signs and symptoms.
Okay, the early warning signs I mentioned to you is a child who with a previous history of contact with COVID or previous history of COVID start showing signs of low-grade fever and the rashes that I described, the activation of the BCG, vomiting, diarrhea. I mean, this can resemble any other infection, but if you should have your antennae up and say that this might be MIS-C. The definitive diagnosis by looking at the high values of SARS-CoV-2 antibody, not the RT-PCR. And then, of course, we can treat these patients with steroids and when required, even IVIG.
So there are many children who are on chemotherapy like methotrexate and other chemotherapeutic drugs for malignancies in the hematological system or other things. Are they candidates for vaccination?
Yes, in fact, I would say that these are the candidates who definitely require vaccination because this is the subgroup that will get severe or moderate COVID if they do acquire it. While we understand that the immune response may not be as good because, as you rightly pointed out, they are immunocompromised. Nevertheless, whatever little they will get will benefit them and therefore they can take the vaccine. And in fact, they should take the vaccine on priority.
Do they need some extra dose, sir?
We don't know yet, but let them take the first 2 doses. I think data will come whether their antibody levels will wane more rapidly than others and they might need a 3rd dose or a precautionary dose like is now being recommended for the elderly with comorbidities.
Sir, you are practicing in Hinduja Hospital. You have seen a lot of tertiary care cases. So what is your experience about pediatric COVID and neonatal COVID? How serious were the patients and what were the things you, as a practicing pediatrician, I would like to know what are the things we as practicing pediatricians should know when to refer such patients to a tertiary care center?
I think, Dr. Rajiv, I pointed out very clearly the red flag signs when the child should be sent to a COVID care center. Regarding our experience,
talking to a tertiary care center, sir.
No, the child should not wait to fall sick enough to go to a tertiary care center. Should be admitted when it's moderate to a COVID care center. And of course, if he deteriorates, he can be monitored there. And if he deteriorates, he will go to a tertiary care center. We have at Hinduja, as you rightly pointed out, a COVID care center for children as well as an PICU for COVID cases. Fortunately, we have lost only 2 cases with COVID. So the number is very small. Pediatric COVID I'm talking about. I'm not talking about adults. And both these children were those who had comorbidities and they were patients on chemotherapy for leukemia. So by and large, the results of treatment of pediatric COVID are excellent. The children recover and they recover almost completely. We still have to wait and see whether the long COVID that we see in adults, I think Dr. Pandit didn't touch upon that, but yes, that might be a problem even in children, but we don't have great data yet on long COVID in children. So that's something we need to watch out for in the future. Thank you.
Thank you, sir.
Dr. Rajiv, can I ask one question?
Yes, sure, madam. Sure.
I was thinking, and Dr. Dhiren Kalavadia has also mentioned, I was thinking whether there should be any gap between COVID vaccination and the routine vaccination. Now, when we have children more than 15 years who will be vaccinated, but there will be in future, there would be vaccinations for the younger children as well. So at that point of time, do we have any guidelines already in place that what should be the duration between routine vaccination and COVID vaccination?
Dr. Sushmita, we don't have any guidelines as of now because, as you rightly said, it's not yet recommended for younger children to take other vaccines. But as a general rule, killed vaccines can be given multiple vaccines together, and we've been practicing this also so far. You know that
Right.
A 6-valent vaccine is given routinely to children. The issue might come only about delaying live vaccines, which are only a couple of them. The chickenpox vaccine and the MMR vaccine are live vaccines. These may have to be deferred, but all other vaccines can be given along with the Covaxin, which, as you know, is a killed vaccine. There is no live vaccine in Covaxin.
So one more small point was about the surgical babies or surgical children who require COVID test to be done before surgery. It's not even RAT. So they may be completely asymptomatic, but they have to be tested. And they could turn out positive. So what are the guidelines going to say in the future? Because this is a huge area.
I thought you would bring this out, Dr. Sushmita, since you are a pediatric surgeon. But yes, there is data, at least in adults, that even asymptomatic COVID positive patients have a worse outcome even after routine surgery.
Right.
Their complication and even mortality rates are higher. Extrapolating that to children, although we don't have direct data in children, it is recommended that you do a RT-PCR so that you can identify these patients. And if it's a non-emergency surgery, then of course it can be deferred till the child is well.
Thank you. Thank you, sir.
Sir, have you seen any long-term sequelae in children? Maybe, almost since the second wave is also over long time back. Have you seen some sequelae like
Not
in
so
adults?
far,
We have seen
not
lung
so far,
fibrosis.
Dr. Rajiv. But in younger children, it's really difficult because I think you know that the symptoms of long COVID are very vague. We talk about brain fog, little lethargy, cognitive dysfunction. In a child who is just a few years of age, I don't think you will easily find these symptoms difficult to identify and say that they are part of long COVID. Personally, in my experience, I have not seen any such case, but we might come across this in the long term. And long COVID can last for even a year or maybe even longer. So we don't know yet.
Thank you, sir. Thanks for excellent talk and enlightening us about pediatric COVID. Let us present a small memento for this excellent talk to Dr. Suhas Prabhu.
Thank you.
Prabhu, sir, thank you for taking time out of your busy schedule and enlightening us. I invite Dr. Jayesh Shah to take over the next session. Thank you, sir.
Thank you. And I would like to leave if I'm permitted.
Yes, sir. Sure.
Thank you.
Good morning, everybody. Our next speaker in the line after the excellent talk by Dr. Suhas Prabhu is Dr. Nandini Kumar. She is retired as the Deputy Director of the Senior Grade of the Indian Council of ICMR and is the Vice President of the Forum of Ethics Review Committee in India. She is an experienced medical profession involved in bioethics education management and has pioneered bioethics education in India. She was a member of President Obama Commission for the Study of Ethical Issues. She is also a National and International Survey of Ethics Committee and is actively involved in promoting awareness about protection of human participants and recent Indian regulation related to clinical trials. Presently, she is a member of the ICMR's Ethics Advisory Committee for ICMR's Bioethics Unit at NCDIR, that is ICMR Institute, Bangalore, and an OP-ISCR, member of the Steering Committee of FERCAP and Chairman of the DSMB for COVID-19 research on Ayush formulation, member of Niti Aayog Committee for Interdisciplinary Health Policy. I welcome Dr. Nandini Kumar. Over to you, madam. Please unmute yourself, ma'am.
First of all, thank you very much for the introduction and a very good morning to all of you. It's actually a privilege to be talking to a number of consultants, veterans, most of them, about research. So because some of you would also be doing research, I suppose this talk might be a little useful for that. I'll be actually touching on the ICMR guidelines and the regulations which would be useful to be applied when you are doing research on COVID-19, as well as certain other factors. So when we talk about humanitarian emergencies and disasters, we have natural disasters, we have man-made disasters, and then we have outbreaks. All of us know that AIDS actually was instrumental in making research, change its ways about participant protection and methodologies of research. Then came Ebola, which further changed the outlook as to how we have to do research. And all of you know about SARS and MERS, and now the present scourge that we are going through. So in 2006, part of chapter in the ethics review procedures of ICMR guidelines actually was devoted to how you have to do research in emergency situations. In 2017, it became a big section by itself, the section 12, the last section. And then in 2020, in the wake of the pandemic, further guidelines were released by ICMR, which addressed ethics committee functioning, but it was also useful for researchers to follow the instructions in that. So the 2020 guidelines actually had 5 topics: statement of general principle, general ethical issues, ethics review procedures, informed consent, and vulnerability of the situation. So the general principles were 10, and this is the same as is given in the 2017 guidelines. These are general and applicable for all types of research. So it has to be, the objective should show that the research is essential to perform. It should not be a futile research, and then voluntary, plus non-exploitation, etc. are self-explanatory. Social responsibility, the ones in greenish blue that you see were the new additions. And when we say social responsibility, it means all research is supposed to have a social value, undoubtedly. But what we mean here is that the research should not actually cause social divides or other ethnic problems. So one has to be careful about that. Privacy, confidentiality, risk minimization, professional competence, which took its root from the ICH GCP guidelines, from 2000 revised guidelines that we had earlier. So these are all self-explanatory. And here, when we say maximization of benefit, one has to attempt to see, both as an investigator as well as an ethics committee member, to see that the benefits have to be maximum as far as possible. And then the main role of institution comes in here, that the institution should have adequate arrangements made for conduct of good research. So it is equally responsible for having good research done in the institution. Transparency and accountability undoubtedly has to be there. And then totality of responsibility. This is again a policy which binds the sponsor, the institution, the ethics committee, and the investigator. So if something goes wrong, one cannot actually get away with that by just blaming the researcher. So all the others also fall into line for taking the share of responsibility. Environmental protection, which was in the earlier guidelines, revised guidelines, it was part of the principle of essentiality, but it became obvious that with the development of science and technology going at a great pace, environmental pollution had to happen, like you have nanotechnology, synthetic biology, etc. coming into picture. which creates a polluted environment for which adequate precautions have to be taken. And besides that, we also have environmental pollution outside, also external, also man-made, which also has to be taken care of, which will be touching. I'll be touching last in this talk. So then we have the general ethical issues where again the blue ones that you see are the new emphasis given to these aspects, that one has to see the benefit and the risk. One has to undertake that analysis and see whether benefit can be more. Sometimes benefit may not be more, they may be equal, and sometimes risk may be much more than the benefit, as you see in phase 1 clinical trials. So privacy and confidentiality again are emphasized here. The distributive justice is how you select the patients for your study. What is the payment for participation, which is different from what you say about compensation, which is research related, or it may also be non-research related, which we say ancillary care. And then conflict of interest, both on the part of the investigator, the ethics committee, as well as the institution has to have policy against this, taking care of this conflict of interest, not influencing the type of research that would be undertaken. Community engagement, community's role has become more important now. So especially in public health research, especially in our present scenario of pandemic, this is very, very important to involve them while designing the study. Post-research access and benefit sharing also has become important. And now we have even the regulations talking about post-trial access. And then, of course, now what you see in yellow is the addition for, all these were there actually already in the 2017 guidelines. But the yellow ones have been added to the 2020 guidelines about storage of biological materials, because lots of materials are being now stored to study, the virus, the variants, etc., etc. And there's a lot of talk about the collaboration that is happening in research. People are now believing more in sharing information than how they used to actually do the research in isolation. Public health and social behavioral research also has become more prominent now because of all of you know how the pandemic has affected both the frontline and the healthcare people, besides the public itself. So the role of agencies, sponsors, and governance of research has become very, very important. And the biosafety in laboratory. I told you about pollution in the earlier the general principles, and this applies here much more because you can do the testing, etc., only in specified laboratories having those biosafety measures in place. So in all emergencies, whether it is man-made or natural or man-made come God-made situations, as we are facing now, there's always an incoherent mental status. People are shell-shocked, there's panic and fear, and all these play a part when you are actually talking of research to do under these circumstances. There's a breakdown of protective infrastructure and human resources for the care and interventions, which we witnessed very well during this pandemic. So in such situation, one should understand what is it that the policy and legal aspect involve, and with emphasis of our country requirements. The Constitution actually describes Article 23 and 29, such situations about social security, prevention of extension from one state to another. A Disaster Management Act came into, it was actually issued in 2005. And with that, you have the National Disaster Management Authority, where PM is the chairperson. State, district, local management authorities are also there. And then you have national and state governments advisories and Epidemic Disease Act 1897, which gets invoked from time to time. And the last one was on March 11, 2020. Besides that, you may have state-specific act or ordinance. So under these circumstances, one has to actually, if one is conducting research, one has to actually take care that they do that within the framework of all these policies and legal aspects that have been described. So the government came out on April 1st, 2021 with the Test, Track, Treat protocol. And each of these actually has a research component there. And MHA order for implementation of containment measure for COVID-19 will remain in force till 31st January 2022. This may get extended also. So under these circumstances, how do you conduct the research? So before I go further into it, I would just like to highlight about a case law which had happened in India much early. So in 1958, there was, I told you the state also can have their own act or advisories, etc. So Orissa had a homeopathic act 1958. So Dr. Chaudhary was a homeopathic practitioner in Puri town. And in Puri, you have this Rath Yatra. So during this time, there's a lot of, incidents of cholera happening. So to stop that, cholera inoculation was being done. And this homeopath actually objected to it, saying that my homeopathic medicine is protective enough. So it went to the court, and the court decreed that the doctor did not act as per regulations. The regulation was what you had to follow, the cholera inoculation. So there's no exemption for alternate protection in the regulations. So if you argue that you have your homeopathic medicine protection, that will not stay here. And he was actually fined ₹5 or 1 week in case he defaulted. Now, presently, I don't know if there are such cases to be illustrated to highlight the fact that you cannot go against the regulations. So we talk a lot about solidarity principle. So there's a lot of interconnections now between governments, national governments. So internationally, there is solidarity. And then government at the national level, the government supports the costs of interventions. And from business point of view, they exercise their corporate social responsibility. And from individual's point of view, the person has to cooperate with the measures in day-to-day life as far as possible. One should always remember that the individual rights can get overridden by the general public good. So in a situation such as what we are having now, actually what the government states, one has to follow. But we still seem to have the freedom to actually object, saying that there's hesitancy, vaccine hesitancy, and things like that. So, and our country is not one where the police will come and take you away and then put you in the place where you'll be forcibly given injections, etc. So coming to the ethical issues in research, as I told you already that these were the guidelines which have highlighted these facts. I'm sorry for the repeat of, I don't know how this has come about. Okay, so constraint on research. There's, you don't have enough time for review and initiation of research. Everybody is in the beginning stage, everybody was in a frenzy. Now it has sort of settled down. And then one doesn't know well about what research methodology is to be taken, what intervention should be used, because everything was gray in the beginning. So lots of drugs came into play, which we say repurposed drugs, etc. And there was inadequate information to say for sure this is the best approach, and inadequate resources, human infrastructure, financial, And then people were waiting for publication of results, which actually led to publication of preprints, some of which were not done properly, not conducted properly. So people were actually, quite confused what approach one has to take for conducting a research. So the prerequisites of research is social value, scientific validity, quick ethics review, institutional facility, and the good participatory practice. So we always talk about good clinical practice, but when we involve the public, when we involve the community, when we involve the participants, then it is called good participatory practice. So it is both from top down to bottom up approach. So they interact and design the study together. So when you have to do research on COVID, there are 4 main things one has to consider. One is registration in the CTRI. People were under the impression that CTRI, one needs to register in CTRI only if it is a clinical trial, because the name pertains to clinical trial registry. But in India, any COVID research, whether it is basic research or clinical research, all have to be registered, which many people did not know actually, and review only by a registered ethics committee. So if an ethics committee is not registered with either CDSCO or the Department of Health Research, then they are not actually the body to review a COVID proposal. One also has to understand that whether it is COVID or not, it has to follow the same rules as for any non-COVID proposal, like the science and ethics should not be compromised. And the quorum of an ethics committee has to remain the same as it has been described in the guidelines and the regulations. So this is just highlighting some points in that, but if you look at the 2, 3, 4, 5, this actually pertains to other streams of other medical systems as well, because there's a lot of claim from the other systems also about protection in mild to moderate case. Of course, they have not highlighted the fact that in severe cases they were not allowed. In many of the states they were not allowed, but in some states and some places, some districts, they allowed them to step in when it was a severe case. And I had recently seen evidence of how severe COVID was actually treated by the Ayurveda regimen. The oxygen from 46 rising sharply within 2 hours, much higher to a safer level. So when you are having such a research, you must have co-investigators from those systems, and also the ethics committee should co-opt experts from the relevant system for review, because not all ethics committees will be equipped to have an expert who is from the other systems. And if folklore and ethnomedicine is used, there's a patenting possibility, and in that case, benefit sharing also has to be discussed. And the quality of product is very, very important, whether it is a modern medicine product or it is a traditional medicine product. So in Ayurveda, use of modern science tools can be, they are using it for extracting, enriching, and validating knowledge, because modern science is not, the property of only modern medicine. Modern science is for all. So those tools can be used for by any researcher. Interdisciplinary collaboration is very important in such cases. And also one should strive for universal acceptance and satisfaction of end users. Even in such cases, it will be better to have controlled studies, because a comparator may give you a better knowledge about the safety and efficacy. So the directives for ethics committees, you all know about drug interventions, very nicely elaborated by the previous 2 speakers. And we have the whole lot of gamut of treatment there, antivirals, monoclonal antibodies, and so on, post-response modifiers, adjunctive therapies, and so on. So if you look at the registry, look at the jump in numbers between 20 and 22. So of course, this is only 1 year plus, it's not 2 years actually. So you can see clinicaltrial.gov jumping to 8,000, and then from 350, EU has jumped to 41. I could not believe it. I went on searching again and again and came back with the same figure. And then Cochrane study register also has increased a number of things. And Cochrane always gives the number within last 3 months. And WHO registry, look at the number, the jump in number, but WHO registry is actually linked to national registries, like even our CTRI is linked to WHO registry. It is linked to Sri Lanka, Thailand, and so on. So naturally, you will get a number of the registration much higher, but compared to 2661, this is quite high. So and this is the value given as on 20th January, and CTRI for that matter has 1373, so almost double the number in a year. So the ICMR's work has been actually National Clinical Registry of COVID-19. So they have 13 sites all across the country, north, south, west, east, and northeast, to report on cases. And then pregnancy COVID registry, novel claim portal. So here all sorts of claims that come in, including the other systems and even ethnomedicine, etc., all go through this portal. And the timeline has been described from December onwards till now. And the total number of testing labs starting from 1 in January 2022 has expanded to 2037 in November 2021. Vaccine development, you all know ICMR's role in this area. And then of course, now ICMR has thought of COVID biorepository. So there are different types of clinical trials that you can do: drug intervention trials, convalescent plasma trials, vaccine trials, stem cell trial, epidemiological research, socio-behavioral research, and COVID registries. So in the intervention trials, of course, plasma trials were a failure, but there were actually consultants, out of the patients were demanding that out of hopelessness, they were saying, can't we have at least plasma trials? They were demanding that. And in some hospitals, the doctors also, out of a sense of helplessness, were resorting to that, despite the fact that it was proven of no value. And then what you see in the orange color are the drugs which actually fail to give the expected outcome. And then, of course, we have various vaccines. Presently, we have 9 vaccines which have been actually approved on emergency basis, and 14 vaccines which are undergoing clinical trials. So what about adaptive trial? We have been talking a lot about adaptive trial these days. It's actually a trial which increases the probability of success for new therapy, maximizes information from the trial within a short time, and allows you to actually have a readjustment of sample size, reduces overall development costs, and reduces the risk for study volunteers and sponsors, maximizes the probability of success with regulators and payers. How that is brought about is actually platform trial design. When we say that it is an extension of adaptive trial, it's a multi-arm and multi-stage. So in one place itself, where you get number of cases, Mumbai has high number, for example. So in a hospital where you get a number of cases like that, in the same locality, you can have multi-arms going at the same time. So you don't lose time. So this is what actually the WHO Solidarity Trial, the biggest global trial with 300 trial sites, tried this methodology with remdesivir, hydrochloroquine, tonavir, and interferon regimens. Actually, when this was not showing any progress, it was thrown out. So you don't have to actually continue, say the period is 3 years. You don't have to continue till 3 years. So in 6 months, you get to know that this is of no use, then you just remove that arm. So like that, you remove arm, you add arms. And then you don't actually lose much time. And one seeks simple outcome measures, not very complicated. No, I have seen outcome measures. You have about 7 or 8 lying down. Laid down for as outcome measures, primary outcome measures, secondary outcome measures. You can't have that many. So what do you want to know about mortality, about the hospitalization, morbidity? What do you want to know? In simple terms, you just try to find out the outcome measures. So the newer antivirals, immunomodulators, monoclonal antibodies, because this failed, except remdesivir was supposed to be okay for the severe cases. But now they are planning to have newer antivirals, immunomodulators. So the other arms will be, these were all flops. So they will be removed and new ones will be added. So same thing went by recovery trial also. So they tried, now they are going to try high dose versus standard corticosteroids. And then in repurposed drug, monoclonal antibodies and an antiviral. Although ICMR-DG has made a statement this is of no use. And I think in certain cases, which was highlighted by the earlier 2 speakers, this has limited value. So what has happened in research now? Actually, HIV had made inroads in the adopting of newer methodologies, newer approaches when there was, affection all over the world with HIV, mostly for participant protection and to get faster results. But now COVID has actually made further inroads in reducing the period. So you have these combining phases, phase 2/phase 3, so you don't lose time, and then acceleration. So this actually leads to acceleration. And of course, the phase 4 is required for certain, I will tell you about that, what the Indian scenario is. So for COVID, you have, ethics committees has to face 3 types of proposals: COVID research, ongoing non-COVID research, and new non-COVID research. COVID research, of course, is not a problem because all the issues will be discussed. But what about the ongoing non-COVID research? Should it be stopped or should it be continued? Especially we had lockdown positions, and even now sometimes we have lockdown positions. So under those circumstances, what should be done? So the ethics committee would advise that all these details are given in the ICMR guidelines. Is it necessary to have a new non-COVID research during this period? Well, if it is possible, the ethics committee would say yes, but there's also another alternative that you can get the proposal approved, and when the time is more favorable, you go ahead with that. But before you go ahead with that, you have to inform the ethics committee. Therapeutic misconception is very high under such circumstances. So informed consent is very important, how you communicate, how the participant understands, whether the participant has the ability to reason. In that case, the legally authorized or legally acceptable representative stands in for the ward or the child. And then documentation is very, very necessary. Especially, when you say oral consent, I had actually asked one investigator, how do you take oral consent? And he looked at me like, can madam ask such stupid questions? That was the look on his face. And he said, oral consent taken orally. Then I said, how did you take it? He didn't get the point. So finally I said, did you document it? Obviously he had not, because he did not know about it. So somebody has to document that. That's why the impartial witness is important there. And you must always remember that the participant and the researcher are partners. That's why they are called participants, not subjects, because subjects means subjugating. Power relations are different, and the participation has to be voluntary. ICMR guidelines on page 50 gives the elements, the essential elements which should be there in the informed consent document. These are the 10 elements, and these are the additional elements. If it is of relevance, you can add this also. About the conduct of research, you may have to relax reporting timelines because there'll be a lot of protocol deviations because of circumstances. You know very well that people cannot actually access the participants because of prohibitions. And then, of course, the medication which has to reach them. So actually, in these 2 years, the pharma companies have devised means how to reach the medicines to them. So it is actually now, it is the, instead of the participants coming to the hospital, it is going to them. And that is a new normal that is being observed now. And data collection is mostly electronic. Electronic e-consent, etc. We used to talk, 2017 guidelines also mentioned that, but now it has become more and more of a reality. And then monitoring. Monitoring is also important. And many times it is the data which is received electronically is also monitored. There is additional vulnerability in such circumstances because of the stigmatization, the risk to the frontline and healthcare workers, the migrants, because they may join you now, but they may leave. And then that leaves you with a half information, and then incapable of giving voluntary consent, most of them, therapeutic misconception also. And then you have to actually look for safeguards. How can you mitigate the risk? Like having counseling facilities, insurance, flexible hours, safety from assaults, etc. Privacy is very important. You can give limited information to the public health authority because they need to know the data. And especially when it is collaborating with foreign agency, one has to actually observe about the data security and data privacy. You all might, I don't know how many of you might be knowing that the data safety bill actually has been finalized in 2021 by the parliamentary committee. Now it is to be seen when it will become effective as passed by the parliament. Patients, family and others involved with patients' care also have to be actually told some part of that, depending on the privacy issues, and the healthcare providers to share information if public health safety is threatened. I would like to mention about MURI. This MURI actually is the concept which actually took root when Ebola actually broke out. So people were not having the drug for treating Ebola. So whatever was there available, phase 1 trial, preclinical trial, phase 2 trial, not yet registered. All those were tried under those circumstances. But there were some stipulations which actually the WHO brought out the document under the circumstances. And what they say is, if there's they can be used only if there's no proven effective therapy and immediate clinical studies are not possible. But the product has to be GMP compliant. Sometimes you may have preliminary data. Risk-benefit analysis is then done by the external scientific advisory committee and approved by the relevant country authorities. Like in our case, it will be the DCGI. Nowadays, the new term is the Central Licensing Authority, CLA. And the EC has to qualify that. There should be adequate resources, rescue medicines, and supportive treatment to minimize the risk. And patients' informed consent has to be obtained. There has to be timely monitoring, and the results have to be shared with the medical and scientific community. Coming to the NDCT rules, it is actually, it came out, the new drug and clinical trial rules came out in 2019, but it was a little futuristic. The Rule 75 has 7 sections, but I'll just talk about the 3 sections. So if the drug has been approved and marketed in countries specified by CLA and no major adverse events are reported, then you can waive off the local clinical trial. But in the case of COVID, this is not yet done. You have emergency authorization by US FDA, etc. So these are well-regulated countries. So CLA may actually, the CLA means DCGI, may actually take a decision on that basis. And then if there is no, we used to say ethnic variation and all that. Nowadays, science has progressed to such an extent that you don't have to actually show the proof in the Indian population. You can have these software users and electronic users to show that the pharmacokinetics and pharmacodynamics, etc., are the same in different populations. And also the pharma companies actually say that in multi-country countries, like in developed countries, as well as in the, suppose it has to do it in Asia, then they will say that in Asian countries like, Korea and all this, Thailand, things like that. I mean, countries like that, they have done it. And in India also part of it has been done it. So that is their argument. So please allow us waiver of local clinical trials. But they have to give an undertaking that they will do phase 4 clinical trials. Now, this is, if you remember the earlier picture I had shown about different phases, phase 4 is after the marketing license has been given. The exceptions to these rules is there for not doing phase 4 also, when the drug is indicated in life-threatening or serious diseases, life-threatening as what we are experiencing now, unmet need in India, and they have described certain diseases like XDR, tuberculosis, hepatitis C, H1N1, dengue, malaria, HIV, rare diseases are often drugged. The other thing is, for drugs intended to be used in life-threatening or serious disease condition, rare disease, and for drugs intended to be used in the disease of special relevance to Indian scenario or unmet medical need in India, disaster or special defense use, etc., etc. This was very futuristic. And on that basis, accelerated approval is given and expeditious review process is done. Now, in January 21, just few days back, 7 days back, in the absence of communication from CLA within 45 days, if you are actually getting your ethics committee registered, if you get no communication from the CLA within 45 days, the registration with CDSCO is deemed to be registered. So there are other stipulations following that. So this is draft rule. It is not yet the final rule. Coming to waste disposal. So a lot of waste is getting accumulated. So research needs to be done how to dispose them. And this is an article, people can refer to that. I have given my slides to AMC, which can be distributed. So you can refer to this, this article to see how it can be disposed. So finally, I would say that guidelines and regulations have to be followed. Research on tests should continue because we get so many variants now. And then emerging methodologies for clinical trials are happening, which is cutting down on the time delay that used to be encountered earlier. Otherwise, who would have heard about vaccine being approved within a year? It used to take years earlier. And then accelerated processes for ethics review, conduct of research, emergency authorization, etc. Finally, I would say that the earlier precaution still stays. Use the mask, keep a distance, and wash your hands whenever required. Thank you for your patient listening.
Thank you, Dr. Nandini Kumar. It was an excellent talk, giving us how to do, what to do, and what should we follow for doing research. Especially many consultants are interested in doing research in COVID, helping further the society. So I think that is a great step towards in explaining what things to be done and how it should be done. There are a few questions. One is by Dr. Dhiren Kalavadia. He said there are various guidelines which are issued by the ICMR, MOH, and Family Welfare Department, state government, local corporation, and they differ on many issues. Okay, which guideline should be followed to avoid medical legal complications?
Very good question, because you see, you are in a state, so the state guidelines will have to be followed. Within the state, you have districts.
Yeah.
So if you are in one district, you will have to follow district's advisory. So I had actually shown one slide where I had told about national advisory. National advisory will be very broad based, and then the states will have to take their own decision on that. Besides the state, then the districts also will come, and within the district also you will have local advisories.
Yeah.
You will have to follow all that, whether you like
Yeah, but
it or not. If you differ in that, you have to bring it up to the competent authorities that this is the way it is done. Because I remember when certain drugs were prescribed for treatment of COVID, some hospitals, actually some researchers in the hospital said, but in our institution head has said that you have to use only this. So then what can they do? They have to abide by that. So it is the onus on the shoulders of the institutional head to follow the right direction.
Okay, thank you.
But still we have the freedom to do that.
Dr. Jayesh, may I ask a question?
Yeah, sure, madam.
There's one comment and one question. My comment is that, madam, hats off to the ICMR team. I'm sure during COVID times when everything was on lockdown, you all have still continued to work. I'm not sure how you all have managed to, come out with so many guidelines, researches, even assessed whether the drugs are applicable, usable or not. And meaning, while the other people were, just dealing with, you have come across all of these things and taken it forward, So now, from my perspective as the president, I would like to ask you, how can the associations participate? How can the process be simplified? Because for each and every individual member, like if you have 13,000 members, every member cannot directly communicate, and the sample volume, the sample size is going to be small if each one person communicates directly with ICMR. So can we pool our resources for all the members who are willing to participate, and an association approaches the ICMR and form some symbiotic relationship?
Yes, you can do that. Actually, I must say that the Central Ethics Committee on Human Research for COVID proposals was constituted in a hurry, and they did highly efficient work in trying to, there were so many proposals being submitted, and they worked overnight. Also, if you take the average, it was 23 point something, their decision. Okay, they were working in the night also, and then giving the decision by 10 o'clock or 11 o'clock, whatever it was. And the period was 72 hours. This is something commendable, because I have been listening to other countries also. In some countries, they take 1 week, actually, verifying, and then coming to a conclusion. So that way, if you see, they have worked fast, and they have brought out the guidelines also fast. Of course, when you bring out something in a hurry, there could be some gaps. So far, not much has been pointed out. But if you have a problem or an issue, definitely as an association, you can approach ICMR and discuss with them, the leadership. And this comes to the corresponding committees. There are so many committees formed by ICMR at the headquarters to deal with each area, like vaccines. For vaccines, there is drug, and each area wise also gastroenterology and things like that. So it will come to them, for finding a solution. And that would be the advice of ICMR.
Thank you, madam. Thank you so much for your excellent talks. I have many more questions, but I think I will keep it for one-on-one communication with you. Thank you again, madam.
Yeah. We like
Thank
to
you very
present.
much for the opportunity. And always I can be approached. My email ID can be had from the AMC. So thank you.
Thank you, madam, for an excellent talk. We like to present the token of appreciation on behalf of AMC, a participation certificate and a memento to Dr. Nandini Kumar. Please accept it on behalf.
Thank you.
Thank you, ma'am. Now, our next speaker is Dr. Ravindra Khembavi. He is a professor in community medicine at St. GS Medical College and KEM Hospital. He's a member of the Hospital Infection Control Committee of KEM Hospital, member task force of COVID-19 at KEM, and was the organizer of many conferences and seminars. He was an additional professor from 2009 to 2021. He started the Yellow Fever Vaccination Center at KEM Hospital in 2019. He is a member of the advisory board at all India level local self-government Mumbai. He is a member of the Hospital Infection Control Committee. He is an examiner for DHA, MPH, PhD at TSS, member of Hospital Infection Control Committee. He is an associate professor in community medicine from 2001 to 2009, in charge of general OPD, immunization, IDSP, started STA clinic in Malwani Health Center, conducted STA surveillance for MDAC, that is AIDS Control Society, and is a member of the core committee of AEFI, Mumbai Municipal Corporation, honorary principal for local self-government, Saurashtra University for DHA. Well, I welcome Dr. Ravindra Khembavi. He will be talking on precaution, dose, transmission, and recurrence. Over to you, Dr. Ravindra Khembavi.
Thank you. I'm very privileged and honored to be speaking on the occasion of Foundation Day of Golden Jubilee of year of the AMC. I am thankful to the organizing secretary for giving me an opportunity to speak on this occasion. So I will be sharing my screen. Final presentation करते हैं.
Is that the final presentation on the right side?
It is not seen to me. So, yeah.
Right.
No. Yeah.
Okay, thank you very much. It's for a slight delay. Can you see my screen, madam?
Yes, yes, sir. We can see it. Make it full screen, sir. F5.
That's
Yeah.
okay.
Yes. Yeah, it's okay, sir.
So I am told to be, I am privileged to be speak on this occasion. I will be speaking on immunization, precaution dose, and recurrent COVID-19 vaccine infection, transmission of SARS-CoV-2. So vaccination alone cannot prevent COVID. There are other measures to be taken. One are personal responsibility and shared responsibilities. Personal responsibility is physical distancing, 6 meters apart, mask, hand hygiene, cough etiquettes, avoid taking off eyes, nose, mouth when you're wearing the mask, avoid overcrowded places and limit to it. And first testing, tracing, contact tracing, ventilation, outdoor, government rules and regulations, quarantine and isolation, contact tracing, and vaccination. If this is just like Swiss cheese, the respiratory virus cheese has multiple holes, and there is possibility that one or the other miss. But if you follow all the guidelines, we'll have 100% protection. So precautionary dose. Precaution means it is a cautious. Government is very cautious. Our PM is very cautious. Actually, it is the additional dose. It is considered a part of the extended primary series of vaccination who do not develop sufficient protection for one or the two doses. It is intended to help these individuals to develop immunity protection as COVID-19. It is given to persons who have some comorbid condition or immunocompromised who will be required additional doses. But government in India started named it as a precautionary dose because it wants to strengthen our healthcare workers and make confidence as the cases are increasing now also, and to the more than 60 years who are been suffered from COVID and died many previously. So this is a precautionary dose. The implementation in India started administration on precautionary dose of COVID-19 for frontline workers, age above 60, and health workers with comorbid others with comorbidities at a time when a country is facing with the steep rise of COVID cases. According to Health Ministry, 1.5 crore health workers and 1.9 crore frontline workers and 2.7 crore comorbid people in 60 plus age group will be administered. The gap between the second dose vaccine and the third dose vaccine is still 9 months. Third dose will be given the same vaccine as the first and second dose was given. This arbitrary 9 months was decided on the basis of each country as their own. When the immunity of the person of the country of the people reduces and the incidents are rising, then we have to give the precautionary dose. Then effect of the vaccine. We still do not know exactly how long the protection of COVID-19 vaccine lasts. But current literature indicates that most of the people have strong protection against serious illness and death and hospitalization for 6 months. Then after it goes on depleting. Now the immunity against COVID. One is pre-existing natural immunity, other is vaccine-induced immunity, and the new term was the hybrid immunity. I will speak on in my session. Now, how long the immunity will be there from the natural infection and from vaccination? We are now starting to see evidence that community you have seen after COVID-19 vaccine. However, the type of the immunity that is developed after infection varies from person to person, and it is less predictable than the immunity after vaccination. So natural immunity after a natural infection, immunity is there, but it varies from person to person. But how it is less predictive, therefore vaccine is the best infection. COVID-19 is a life-threatening disease that can have long-term consequences. We need to WHO has authorized COVID-19 vaccination. Safety. Many people have been given vaccination without any side effects, very few side effects. It is much safer to get vaccinated than having to risk COVID-19. Get vaccinated as your turn comes and keep doing everything so that you can protect yourself, like wearing masks, social distancing, hand wash. We don't know after COVID infection, there are multiple complications, neurological, cardiovascular, respiratory, skin reaction, long COVID, etc. So vaccination is the best preventive measures along with other measures as well. So vaccination protection timing. The vaccination takes about 2 to 3 weeks for the final vaccination to fully effective. It is especially important to continue all the precautions during the period to protect yourself and others. And the vaccination protection varies from person to person. Now, vaccination protection, vaccine does not provide full protection, 100% protection. So breakthrough infection can happen, but as more people get vaccinated, expect that fewer will come in contact with the virus. That is the objective. That is we have to achieve herd immunity. For achieving herd immunity in COVID-19, it is expected that you should cover more than 70 or 80% of the vaccination, so that most of them are immunized and others also will get, that is herd immunity, community protection of which is very difficult task to achieve. Then when you have been vaccinated, you have to follow all the safety measures for social distancing, cough etiquettes, wearing masks, ventilation, and hand washing. Now, when your term comes, you should get vaccinated. All approved COVID-19 have been thoroughly tested, and all provided a degree of protection against getting serious illness and dying from the disease. Then it is important to vaccinate as soon as possible. Each and everybody in the community should take vaccination all over the world. All the third world countries always should be vaccinated so that we can, all the world lives in harmony. Vaccination available in India. Vaccination started on 16 Jan 2020. Covishield was started. Then Covaxin was subsequently given permission. Vaccination first was given to health workers, frontline workers above 60 years, then 45 years above with comorbidities. Then it was given to adults above 18 years and above. Now it is given to 15 to 18 years above. And now precaution road is to booster the health workers, frontline and 60 and above as a cautious. So as the pandemic as cases were increasing. Now equitable distribution of COVID-19 vaccine. As per WHO, vaccination should be given to each and every country. So the WHO guidelines says that primary vaccination should be given to each and every country. WHO has not advocated booster dose or precautionary dose at all. It says that first, if all the countries are given, then there will be a protection. But as you know that South Africa, many countries where the people were not given, therefore we got a Omicron variant which was established, and this has created a third wave. On November 23, 2002, a total 107 countries are providing additional or booster dose and some segment of the population. Population coverage fully primary series is less than 100% in 45 countries and less than in 105 countries. Now this hybrid vaccination, hybrid rigor can occur when different plant trees are tried to bring together. Hybrid is much more stronger plant. Sometimes similar happens with the natural immunity. It combines with the vaccine generated immunity, resulting in 20 to 100 times higher antibody response given by the memory B cells and CD4 T cells and broader cross protective for variant. The natural immunity, the immunity is compared to antibodies of our memory cells and T cells are less. Vaccinated also it is comparatively more than natural immunity, but in hybrid immunity the antibody response and the cell mediated immunity is more, and the term hybrid implies to individuals with prior SARS-CoV infection and then vaccination against SARS-CoV or vice versa. So that hybrid immunity has told that it is more effective in controlling preventing the COVID infection. Now, effectiveness of vaccination against Delta variant and Omicron. With the research suggests that COVID-19 vaccine are less effective against Delta, but Pfizer, BioNTech, Moderna, and Johnson & Johnson COVID vaccines give some protection against severe COVID. In case of Omicron, it is expected that people who are fully vaccinated likely to have breakthrough infection and spread the virus to others. However, COVID-19 vaccines are expected to be effective in preventing severe form illness in case of Omicron. The variant is also might reduce the effectiveness of some monoclonal antibody treatment. Those who are suffering, as suggested by Sir also, that Omicron, the monoclonal antibodies are not effective. So booster dose. So this question is that whether booster dose is required or not. Booster dose is an additional dose of vaccine to the community when complete primary series of vaccination 1 or 2 is over, and when the time immunity and protection falls below a deemed sufficient in that population. So that should be decided by the each countries, researchers and all that. Then are the boosters satisfied? So this is a slide from CDC government which shows that among more than 65 years age, 481 persons needed to be vaccinated with 1 booster dose to prevent hospitalization. If 50% needed to be vaccinated with primary vaccine to prevent 1 hospitalization. So primary vaccination is important. Among 18 to 29 years of age, 38% need to be vaccinated with booster dose for 1 person to be hospitalized, while 396% needed to be vaccinated with primary series in 18 to 29 to have one hospitalization. So vaccination in primary series, especially in high risk population, remains top priority of everywhere, because this will ultimately lead to greater reduction in severity. So this slide indicates that there is the booster is not justified. We have to give each and every people of the world primary vaccination, so that the protection will be there to the community as well. Now, analysis done by the state published in TY 26 January page, the data of the state government of patient of admitted from December 1 to January 2021 within 50 days shows that total cases which were admitted in the state were 4,598, out of which 2,534 were unvaccinated and not suffered from COVID infection, and 199 were death through infections after one or second dose. 74 cases of reinfection in non-vaccinated, and 91 cases of reinfection as well as death through infection. This is the data available, fresh data available, or previously we had data of other countries, but this is the data recently published in TOI. Then the morbidity studies in the same shows that 278 deaths out of 4,596 occurred. Maximum deaths occurred in 175 people, and they were not vaccinated and they were not suffering from COVID. So vaccination is an important method of prevention. And 35%, 99 deaths occurred in 35% were fully vaccinated or partially vaccinated. So vaccination does not that you will be preventing from death. That is, you have to follow other preventive measures. And where but 2 people, that is 0.2% among those who had natural infection from previous infection also died, and 2% with natural and vaccine immunization also died. So the Dr. Banerjee, senior clinical epidemiologist from Pune, people with natural immunity have infection are 24 times more protected than the people who have only vaccine-induced immunity. So natural infection has much protection. But Dr. Sanjay Pujari, member of the National Task Force, mortality is higher among unvaccinated, in 40% higher than the breakthrough infections. So death rate is lowest in the hybrid immunity, the natural infection to the vaccination. Similarly, Israel study also showed that those who have hybrid immunity, this 13 times more robust immunity developed after vaccination. Then the recent studies also show that. Then they have done ICMR study done on published in ICMR and NIV studies, which was recently pressed, very good data, which was published in Times of India 28. The findings were done over the blood samples of 39 out of the 28 returning from UAE, US, UK, Africa, and the contacts of all confirmed Omicron cases. Vaccinated group had received Covishield and Pfizer BioNTech shots, and the result shows that those who are vaccinated, 13 Covishield, 13 were asymptomatic, 12 had minor fevers and cough lasting for 1 to 2 days. Individual vaccination with Pfizer one had 1 milder fever and cold throat, while rest 7 had no symptoms. So Pfizer has a higher protection against Omicron compared to this. That is, as per international publications also suggest the same thing. While unvaccinated, 6, mostly pediatric, with mean age of 16, out of which 1 was adult, were asymptomatic. 4 were asymptomatic. 2 pediatric cases had mild fever, and this was their conclusion that the individual affected to Omicron have significant immunity developed with antibodies and neutralizing capacity and effect to not just Omicron, but for other variant concerns. So this is a good news, which shows that Omicron is effective and it's spreading like anything, but it has antibody potentials and it has soon replaced Delta. That is the prediction, which should be good. Then recurrent. I will go about the topic of recurring COVID. reinfections, transmissions of COVID, about catching COVID-19 twice. So this is a reinfection, but the reinfection, according to ICMR, 2 positive tests at an interval of at least 102 days with 1 interim test negative with SARS are reinfection by the Indian scientists for establishing surveillance according to ICMR. So this is the Indian ICMR definition of reinfection, while CDC and the Europeans say that duration of 90 days from 2 positive SARS along with genomic evidence of reinfection as the investigation criteria to understand the phenomenon of infection. CDC and European CDC suggest that use of genomic evidence of confirming the reinfection. However, epidemiological working definition will be more pragmatic, help to assist the magnitude of reinfection and reinfection in population and resource constraint setting. So doing genomic studies is very difficult, and you have to collect blood of many people to prove that whether there's a reinfection should be, or it's the old infection. But this definition stands, ICMR definition stands the hold of the test. Now, the health system worldwide has still not achieved control of severe acute respiratory coronavirus 2. SARS-CoV is highly transmissible, potential secondary attack rate of 17%. The rate of transmission has reported even higher in circulating variants like B117 than in pre-existing variant. In addition to high burden, the virus has brought unprecedented downpour of social and economical setback, the course of which cannot started to be, it is reversed until the herd immunity or artificial immunity is achieved. So you should have a herd immunity or artificial to be achieved, which is a very difficult task. So we have to adopt all preventive measures till then. The effect of vaccine and reinfection. So how the vaccine, while the 6 vaccines have already licensed, we are still far from herd immunity, giving the variant will produce at least a scale, and the vaccine should be at a scale which is affordable, allocated globally, it should be used. Additionally, in considering an emergency of variation, a report for recurrent COVID in global battle against the virus is far from being over. Immunological evidence suggests that immune response to post-natural COVID when it's a transition reported depletion of antibodies in first 4 months, followed waning within 1 year. So whether a booster should be given is a big question. In ICMR study, the present investigation contributes to the goal. An Indian study shows that it is about 4.5% reinfection by the ICMR in India. That is the Indian study scenario. So then, thank you very much for patiently. And this is about my presentation of reinfection, and the questions can be asked about. I will stop sharing my screen.
Yeah, thank you, Dr. Khembavi. It was an excellent talk. It was making us understand how the immunity, how the vaccines work. There are many, many questions which are there in the chat box. I just start.
Yes, sir.
Two common questions are there. That suppose someone has had a mild sore throat fever recently, okay, should he take the second? Should he take the booster dose? And if yes, then at what interval?
So it is not the precautionary dose. Government has taken only as the vaccine is limited. You have to, only the high risk group should be take the vaccine. That is
suppose
above
the person is a doctor himself.
So he can get tested, and if it is positive, then he should not take the vaccine. He should take after 3 months as per government guidelines. Okay. After the waning of the infection, after 3 months, the vaccine should be taken. Ideal.
Okay. Now, what about the hybrid vaccination, sir?
So hybrid vaccine is the natural phenomenon which occurs because as you know that the COVID is highly infectious. The hybrid vaccine in due course, those who are vaccinated, either those who are not vaccinated had the disease and that afterwards they got vaccinated. These are hybrid cases, and others who had vaccinated and they got the disease, that is the reverse disease, they are also called hybrid vaccination. And it is known that this hybrid vaccinated people have more immunity than the usual vaccinated, because they have got more two components. One is the natural immunity which is there, and also vaccine immunity. But it's very important to understand that it is very important to understand that the natural immunity which is there, at what cost? Because COVID-19 has got many complications, and long COVID is there, and we have got many black fungus, white fungus, and cardiovascular. It is better that each and everybody get vaccinated against the COVID vaccine. But the international vaccines which are there, the Moderna and the Pfizer vaccine, are good, but they can't be used in India because the temperature setting of giving the vaccination is very low, and keeping the monitoring is very low, and therefore these vaccines are not available in India. But Covaxin and Covishield are sufficiently. Covaxin studies of the effectivity of is not still known, because whatever foreigners who came, they have taken either Covishield or Pfizer, but we have not till about Covaxin. But it nevertheless, as a field vaccine is there, it has some protection as per government guidelines and WHO as well.
So which vaccine can be given during pregnancy and at which trimester?
So initially, when the vaccination program was started, pregnant women and the mother who were breastfeeding were not given the vaccines, because of there was no sufficient evidence showing that whether mother to child transmission occurs or not, about why the breast milk also transmits the infection from mother to child. But now it is clear evident that there is no transmission from mother to child during pregnancy as well as breastfeeding, and the vaccine can be given to the pregnant women and PNC anytime. As it was given initially, it was started after the evidence had come, and we started giving the vaccination.
Okay, sir. So what about taking a Covishield vaccine after taking Covaxin, hybrid vaccination?
So as such, the research are still going on about the. No, it's not hybrid. It is about the
mixing two doses.
Mixing doses. These mixing doses research are going on, but there is no foolproof evidence that there is the trials are going on. But it has got no WHO approval of the vaccination. So till then, Government of India is test only on giving the same vaccine booster again. So
okay.
There's no question of giving it.
Okay. Acha, so you mentioned 102 days. So in between that test, one test has to be done which has to be negative to call it the reinfection.
Yes. This is ICMR definition, but whether in this reinfection which data was shown, whether what definition was used and all that is very difficult to say, and the patient's response when he had sign symptoms and when it was there. So that many people on the say that they may be carriers, they may be shedding the virus. Now even it is said that after 14 days also the virus is shed. So but this virus is less virulent than therefore there is no need of quarantine and all that. Therefore these measures, even nowadays when Omicron is there, now the quarantine period has, previously it was 10 days. Now it has reduced to 7 days, showing the so it is seeing whether how long the protection will be there. Yes.
So with the newer variants coming, okay, will the vaccine be effective? Will the vaccine producer be taking into consideration the newer variants with the new batches of vaccine coming?
Hello, sorry, I am interrupting you, but can we start the panel discussion and Dr. Kembhavi also part of that?
Okay, madam, just a minute. Yeah.
So see, the variants are going to come until whole world is.
Kembhavi sir, we can take this in the panel discussion.
Okay.
This question the moderators will ask.
Thank you, madam.
Thank you. We'll present a certificate and memento to Dr. Ravindra Kembhavi on behalf of AMC. Thank you, Dr. Ravindra Kembhavi, for an excellent talk. Now I hand over the mic to Dr. Vikram Khanna and Dr. Qayyum Muqaddam.
Thank you, sir. Thank you for. I'm very privileged to have this honor. Thank you.
Sir, please stay on for the panel
Yeah,
discussions.
yeah, I'm there.
Dr. Vikram?
Yeah, thank you, Dr. Jayesh. Am I audible?
Yeah, you're
Yes,
audible.
you are audible.
Yeah, I welcome my fellow moderator, Dr. Qayyum Muqaddam, who's a MD in pharmacology and a managing committee member of AMC. Currently, he is the area representative from rest of Mumbai area. I am the joint secretary of AMC currently. Our first esteemed panelist is none other than Dr. Mangala Gomare, who's the executive health officer in the Mumbai Mahanagar Palika. She is also the chairman of the Sexual Harassment at Workplace Committee. She has worked extensively for COVID-19 preparedness, isolation facilities, inter-hospital coordination, technical inputs in planning and formulating the various guidelines. She has been instrumental in planning and implementation in the family welfare, maternal and child health, and the communicable disease and the malaria control programs. I welcome you, madam. Our next panelist is Mr. Jahangir Gai, whose column we read every Monday in the Times of India. He is one of the senior most consumer activists who has been appearing in the consumer courts since their inception. He has also received the Government of India's National Youth Award for Consumer Protection. He is a columnist for Times of India, Business Standard and Mumbai Samachar, and gives talks on various consumer awareness forums. His unique quality is that he is not biased towards any individual or sector and attempts to improve the system. Welcome, Mr. Jahangir Gai.
Thank you. Good afternoon, everyone. It's my proud privilege to introduce our other panelists today. We have Dr. Tanu Singhal, who's a pediatrician by qualification and has also done course in infectious diseases from the London School of Hygiene and Tropical Medicine. She is currently attached to the Kokilaben Dhirubhai Ambani Hospital, Mumbai from 2009, and she is an executive board member for Fungal Infection Study Forum, and also an RNTCP National Expert Group on Pediatric Tuberculosis. To her credit, she has received the Dr. I.C. Verma Excellence Award in 2020. Her interest areas spread from COVID-19 to tuberculosis, antimicrobial resistance, infection control, travel medicine, vaccinology, and biostatistics. She has a lot of publications in peer-reviewed international in index journals, around 82. She has 3 books to her credit and has also contributed to 20 book chapters. We also have Dr. Balkrishna Inamdar, who is a vice president, was a vice president in 2007 to 2008 of the IMA Maharashtra State Branch. He was also the president of IMA Mumbai West from 2010 to 11. He is the national chair, Safe Motherhood Committee of IMA from 2019 to 2020. He has been the coordinator, maternal and child health for the Rotary International. He is the chair, National Advisory Committee, Health for Rotary India. He has been a MMC accredited teacher in obstetrics and gynecology. He has been a technical advisor to the government of Maharashtra for bill against sex determination tests. He is the founder of Forum of Doctors Against Sex Determination and Female Feticide. He's a district governor. He was a district governor from 2012 to 13 of Rotary District 3140. And he also is running his own hospital, Datta Maternity and Nursing Home, NABH certified hospital in Goregaon West. A warm welcome to all panelists. And now I request my colleague Vikram Khanna to start the panel discussion.
I just want to interrupt over here, please. Moderators, please allow me to speak. Dr. Mangala Gomare has to go. She has we have already had some delay in starting this panel discussion. So can we take her questions first, please?
Yes, sure.
Yes, madam.
Yeah, good morning, everybody. And to all the fellow panelists also. At the outset, let me thank Dr. Sushmita Bhatnagar, madam, and all the office bearers of AMC for having me here. And I really wish and congratulate for you are celebrating this Golden Jubilee year this year. And I wish many, many more glorious years to come ahead. for this very noble cause of medical professionals. Should I start something, or I'll take questions only directly?
Madam, we have a few questions. If those are in sync with what you wanted to say, then you can cover the remaining points later.
Okay, okay.
So, Madam, our first question to you, which is the burning question in everybody's mind, is what is the BMC's plan for opening up schools, colleges, malls, office, etc. to the full capacity? And will wearing a mask be still mandatory? And what would be the possible time frame?
Already many speakers, they have enlightened us with all the aspects of the COVID management and public health point of view also. I think Dr. Suhas Prabhu has told in detail about this, but still let me tell you the situation right now in city of Mumbai. We are facing now the third wave that is called the Omicron wave. First case started from exactly on 11th of March. We had the first case of COVID from Andheri West area, and still we are getting cases. We are facing wave after wave, and we are going to complete the 2 years. It is not happy to tell you, but still 2 years ahead, we are still in the COVID management. And we don't know how many variants may come in the future and how many waves we may have to face. But in first wave, generally we say from March to December 20, we had around 184,000 cases reported during that wave. Then in second wave, from January 21 to November 21, we had 781,000 cases. That was the biggest number of cases reported in second wave. That lasted for 11 months, to be very precise. And then the third wave came with a very surprise. We were waiting for the third wave to happen before, but fortunately, maybe because of epidemiological situation in city of Mumbai, because of lot of intervention, vaccination performance, and it got delayed. And then we had this third wave of Omicron from maybe second or third week of December, and still we are facing those cases here. So we have reported around 2 lakh cases in third wave. Positivity rate, as far as it goes, number of tests we are doing as per the ICMR guidelines, as per the Ministry of Health and Family Welfare guidelines. And even it is comparable with many mega cities of Mumbai, metro cities of, India, and as well as international cities. So we are doing, we have done 23 lakhs tests for in first wave. We have done more than 1 crore test in second wave and 25 lakhs test in third wave. Now the situation is like in third wave, we started getting maximum number of cases, maybe more. I think on 6th and 7th of January, we had more than 20,000 cases reported in a day. And active number of active cases surpassed 1 lakh. I mean, 1 lakh, 20,000 cases were there in a day on, I think, 14th or 15th of January. So this was the magnitude, but one thing was very clear into this was Omicron is not so serious as compared to the Delta and Delta variant. We had cases only with the upper respiratory tract infection, sore throat, cough and cold, and not needing admission in the hospital, not needing oxygen support because their oxygen saturation was not going down. So this was a very good thing that has happened because of Omicron. And let me tell you, we are doing that whole genome sequencing surveillance also in city of Mumbai. And very happy to tell you that Mumbai is the first city who is starting this kind of genome sequencing. We have a laboratory in Kasturba Hospital, molecular lab. We have done up till now 8 rounds of testing. And in the 8th round, I'm really, really happy to tell you that 80 to 90% cases are of Omicron, and which is of not so severe cases. So this is the situation in Mumbai. And as far as the question concerned that when we are going to open the schools, definitely we would like to open the schools as a BMC. But as Dr. Prabhu has said, we have to weigh the pros and cons. What are the benefits and what are the risk factors involved into that? And as far as public health is concerned, let me tell you that whenever there is a situation when it is not posing as a threat to a community at large, or it is not no more a situation which is a public health concern, then definitely things will get unlocked. And since we are facing this pandemic, the policy decisions are always taken at very high level, taking into consideration the suggestions given by task force. And many members were there, esteemed members, Dr. Rahul Pandit, Dr. Suhas Prabhu, Dr. Shashank Joshi, Dr. Oak, and so many members are there who are guiding us time to time. So definitely in the near future, schools may open. That much I can say.
May I react to this?
Please go ahead, sir.
Okay. Now, being connected to a school, on 4th of January this year, we were asked to open up schools. Suddenly, we were told that no schools till 15th of February. On 21st of January, we were asked to open schools from 24th. So there are contradictory instructions. Everything is unclear. It seems that you are still not certain whether school should open or not. One more major question is the efficacy of the vaccination. Today, school students are not vaccinated, yet we have got a directive to start the school. If vaccination is essential, why should you start the school prior to vaccination? And if vaccination is not essential, then forget about it, start it immediately. So these are conflicting things. What happens if one student or one teacher falls sick? Do we close down the school again? So there is a lot of unclarity, a lot of misgivings. Could you please throw some light on that?
In fact, sir,
yeah,
that was our next question also to Gomre madam, that what are the BMC plans for expediting the vaccination for the 15 to 18-year age group, and when will the tentative vaccination start for under 15 age group?
Actually, all these questions should have gone to Dr. Suhas Prabhu, who is the chairman of the pediatric task force and also the task force of Maharashtra. But anyway, whatever epidemiological situation is there, that I can highlight and I can share with you. As far as this vaccination is concerned, there were different milestones, as Dr. Kembhavi also has told us. On 16th of January, we have started the vaccination with frontline workers, then healthcare workers. Then it started for 60 plus citizens with comorbidities. Then it started for 45 plus from 1st of May. Then came the pregnant ladies, lactating mothers, bedridden citizens. And now another milestone has come from 3rd of January, that we have started this vaccination for 15 to 18 age group. And then on 10th, we started the precaution dose also for healthcare workers, frontline workers, and 60 plus with comorbidity. So all those, looking at the milestones and the performance, again, I would like to tell you that the Mumbai's performance is one of the best in India. Mumbai city has done a very good work as far as vaccination of citizens is concerned. And I'm very happy to tell you that first dose, as per CoWIN app, you must be knowing about the CoWIN app. Everybody is registering on that. 113% coverage has happened of the first dose. Exactly, we have covered more than 1 CR doses given first dose. Maybe some people from the MMR region, they have come to Mumbai and they have taken the first dose. So we are doing more performance, more than 100%. But then second, as far as second dose is concerned, we have covered 86 lakhs doses. So covering exactly percentage wise, it is 94%. So this is the situation of Mumbai as far as performance of vaccination is concerned. And let me tell you, because of this, maybe we have not faced serious consequences of COVID. And all cases, though there were more number of cases, they were Omicron, and maybe vaccinated cases were also there, but then there were very less number of severe cases, very less admissions happened, very less people patients required oxygen. and very less death rate also has been reported. So this is maybe, I can say definitely because of vaccination and good coverage performance and herd immunity in city of Mumbai. The third wave consequences are lessened, reduced.
Madam, one more question is, why has the Dharavi model not been so successful in other parts of Mumbai and Maharashtra?
When we see clear-cut 3 waves, first wave was really dominated by slums, various slums affected in city of Mumbai. One of them was very famous Dharavi slums. Then we had Jijamata slums in Varli area. Then we had Kolivada area in again G South area. So I will never say that Dharavi model was not successful and not being successful in other areas. It was successful. And Dharavi model definitely has emerged as a successful model whenever containment measures are being taken for COVID pandemic. In first wave, it was really dominated with slums getting affected with COVID. And then because of this Dharavi model only, we could contain all the slums and we could prevent further prevention of COVID in slum areas. When we see the second wave characteristics, it was predominantly in the non-slum areas and all affluent and posh areas. So in second wave, mostly we have not seen the slums getting affected. So that was the success of the Dharavi model.
Madam, our final question to you is, how can AMC as an organization help BMC in expediting the process of ending this pandemic very soon, because we are a body of medical professionals. So in what way can we participate in helping BMC to eradicate this pandemic?
Whenever professionals like AMCs are concerned, you have a very pivotal, crucial role you are playing, and in further future also you can play a great role into this. And when we had a first wave, many small clinics, nursing homes were closed. And because maybe they were scared, even doctors were scared to come out. Enough protective gears also were not available. Plus their staff, paramedical staff also were not available to open the clinics and setups. But then when a lot of meetings happened with the then municipal commissioner, we had a special dedicated WhatsApp group also to reopen the nursing homes and clinics. And many doctors were provided the PPE kits from BMC to all the general practitioners. And also a lot of help has been given from the BMC to start the nursing homes, to reactivate the nursing homes. And I think with that appeal, many nursing homes, they got opened, and management protocols were given to them. They were all, the doctors, they were following all those protocols. And definitely with the help of the private sector and MCGM and the government, we could lower down the number of cases, reduce the number of cases in second wave. But then third wave came in a different way. And now we may say, is this a start of the end of the pandemic? Yes, we can say that, provided there is no another variant coming in with a different characteristics. With this Omicron coming in, we can say it's always a blessing in disguise. Omicron cases are coming in, they have replaced all the Delta variant. Right now we have only, can say as per the WGS surveillance, 10 to 15% Delta cases are there, or Delta derivatives are there. So mostly we are having Omicron cases, and they are getting treated immediately. They are manageable, they are having mild and moderate symptoms. So AMC can help us in various ways as far as public health is concerned, having great awareness about this disease. Though cases have been reduced, we cannot lower our guards still, because still cases are coming in, and some percentage of Delta cases are there which are worrisome for us. So Delta cases may turn up serious, as well as death rate is also high in Delta cases. So we have to have that vaccination strategy in place. You can inform people that to get vaccinated, because we are seeing a lot of Anti-vaccine lobbies are coming up, they are becoming active, and they are giving wrong messages in the community. For that, all the members of this esteemed AMC association, they can come forward, they can really inform the citizens that they should get vaccinated, and precaution dose is also available for the senior citizens, so they can go for that. That is very, very important. As Dr. Kembhavi has already informed, precaution dose when we can take it. Only thing is that if you are infected prior, then after 3 months you have to take the precaution dose. Other two things he has already mentioned. This is very, very important, and still COVID appropriate behavior. There is no alternative, no choice for that. So we have to follow that very rigorously. That is very important. Still, we are getting around 1,500 cases in a day. And still now, as I told you, in third wave on 6th and 7th, we had maximum number of cases of COVID, and then admissions increased after that. So that peak is now we are getting, and now we are getting in deaths in double digits. So we have to be cautious for that. And still COVID appropriate behavior is very, very important. And that is and another thing is that very clearly we have told about when to get admitted in the hospital and when a case can be managed at home. Again, being a doctor, a special doctors, patients always, they listen to you, they follow you. So please tell them unnecessarily we just cannot block the precious beds available in DCH and DCHC. That is again very important. In the third wave, we have seen that admissions immediately increased, though there were no criteria or for the admission, or there was no what I can say, that was not the situation to get admitted in the hospital. But still affluent class, non-slum people, they always occupy the beds in private hospital and in ICUs. That is very detrimental to any implementation or execution of a public health program. So this is again very important. We have to tell the patients that when your oxygen saturation is not going down below 93, your fever is controlled and it is being managed with the antibiotics and home care. So then in that case, you need not go and admit in the hospital. That is again very, very, very important. And as far as containment measures in the community are concerned, we have changed our protocols and guidelines time to time, looking at the situation of the COVID characteristics. In the second wave, we were sealing the floors, we were sealing the buildings, following different criteria. But in third wave, we have already issued the guidelines that if 20% of the flats in of a building are affected with COVID, then and then only we will seal the buildings. This is very important. So we have to balance all the social life, economic life, and the disease progress. So looking at that, we are issuing different guidelines. So we are sharing those guidelines with everybody. So you can follow that also, and you can counsel your patients, you can tell them what are the appropriate guidelines. Now even home isolation guidelines are changed. Now we are asking people to only isolate for 7 days from the date of onset of symptoms or date of testing. And after 7 days, there is no need of testing. But now again, latest ICMR guidelines have come that after 7 days you can test, and even high risk contacts who are there around the lab confirmed case, they also need to be tested after 7 days. But that after 7 days you are declared as discharged. So that these are the latest guidelines which they can follow. But 7 days they have to follow the isolation strictly. Otherwise they will spread the infection. Younger ones, if they catch the infection, they will not go into seriousness. But yes, if there are senior citizens around, pregnant ladies around, comorbid cases around, then definitely they will land up in seriousness. So that we'll have to take care. That is very important. Another thing is that now the cases are coming down, but since Mumbai is an international city and all kind of international passengers are landing here at the airport of Mumbai, so we have to be very, very vigilant at the international airport, following what is happening there at worldwide, because Omicron cases started first in Botswana, South Africa, and all those countries. And immediately we started the surveillance at the international airport. We started quarantining all those passengers coming from the high-risk countries. So that has really saved us. That was very well managed at the airport, that also I can say. So whenever now we'll have to be vigilant, still we have not so less number of cases. So we have to be following COVID appropriate behavior. Wearing mask, yes, still it is continued. Maybe if task force recommends, then maybe it will be decided by them.
Yes, madam. We are waiting not only to unlock fully, but also to unmask fully. And hopefully we'll be able to recognize each other without a mask.
Yeah, that is really important. Since last 2 years, we are not looking at anybody's face and we are not really recognizing. That is really important. I am also looking forward as a public health person. Really that situation should come that we are off mask.
Yes, madam. Thank you very much for your valuable inputs. And the BMC is doing a fantastic job, and we at AMC as an organization and the members will do our best possible to help you in implementing all the guidelines and measures and eradicating this pandemic at the earliest. Dr. Qayyum, is there any other question from the audience for Gomare madam?
No, we haven't seen any. There was only the question from Mr. Okay, we'll just see.
The BMC is doing really good work, so there are no questions.
Yes.
Thank you.
Thank you, madam. Thank you. Personally, thanks to you. In spite of your busy schedule today, you had told me that, but you had come.
I am really happy to be associated with AMC. I am really, I mean, I was active member of IMA, but now because of other commitments, I am not able to contribute much. But definitely, I really love to be associated with medical associations. Thank you.
Thank you so much, ma'am. Thank you. Thanks a lot.
Our next question will be to Mr. Jahangir Gai. Sir, are you there?
Yes, very much there.
Yeah. So, sir, the first question to you is how should we tackle the group that is opposed to wearing masks and opposed to getting vaccinated?
I don't think you're required to tackle them. Let each individual decide what is good for him or what is not good for him. Let us not infringe upon anybody's rights.
Thank you, sir. The next.
Can I say something here? I just wanted to add something.
Please, madam, go ahead.
Yeah, regarding, I just mentioned about the lobbies, anti-vaccine lobbies, they are really becoming active. So I would like to appeal to AMC members also, being a doctor and in the interest of the public health as such, we should not advocate anti-vaccine policy. Individually, maybe you can have your opinion as an individual, but when we say, when we counsel to the citizens, when we tell something about vaccination to the citizens, we should not advocate the anti-vaccine propagandas or anti-vaccine opinions regarding that. That is what I would like to appeal. And as members of AMC, you also, I will request all of you to please inform citizens regarding benefits of vaccination. And again, I would like to reiterate that because of vaccination and good performance in the city of Mumbai, we are saved from the third wave. We can say that from turning patients from mild to severity and reducing the number of deaths. This is really very important. Though vaccination will not prevent us from getting infected, but yes, it will definitely prevent from turning into severity and reducing the deaths. Thank you.
The next question is to Mr. Bal Inamdar. So how can Rotary as an organization extend help through its network to spread awareness about the precautions to be taken and also for vaccination?
Let me at the outset thank you, Dr. Sushmita and others who have invited me, Dr. Rajiv, Dr. Vikrant. And let me also compliment AMC for the Golden Jubilee year. I think it's been, I've been part of AMC for quite some time, almost 3 decades. I've been a member. I always call myself as a disciplined soldier of AMC. So I follow all your instructions to the T, and thank you so much for being such a great help to all the consultants. I bring greetings from my governor, and I must say that because he is very busy in Palghar for doing some projects, he has requested me to stand in. So I'm as usual, since I'm speaking to AMC, it's a great pleasure once again to be part of AMC panel. Let me first quickly go through what Rotary has done so far in last. So from that we'll take the cue for the future. Take for example the vaccinations. Now Rotary is known for the facilitation, and Rotary is known for the corporate world interaction with corporate world. The number of clubs who have done vaccinations independently, along with CSR. So, for example, CDSL has given CSR to one of the clubs, Rotary Club of Bombay Queen City. Ratnakar Bank has given CSR. So we are in the process of picking up a lot of CSR funds, almost to the tune of more than 1.5 crores so far. So we have done numerous vaccinations. You must have heard about the drone experiment, which took place where the vaccines were reached through drone to a remote area. That was one of the Rotary clubs was involved along with Government of Maharashtra, and we did that drone experiment, and it was very successful, and it's probably a future for the next wave of vaccination, how to reach vaccination to remote places. We have been doing number of projects on sanitizers, and recently we gave almost 2 lakh sanitizers free of cost to the community. And with the food giving rations, it came to such a pass that at one point of time we thought that the rations have been given for too many people, for too large a quantity. Hence we stopped giving rations because we realized that some of the rations are coming out in open market. So that was something which was not very good. We have given a number of ambulances, believe me. And you know that in an ambulance, we have a tie-up with Mahindra, and also we have something called as COVID-specific ambulance. So it took some time for us to get to that COVID-specific ambulance, but ultimately we could manage that. We have been upgrading hospitals, oxygen concentrators, ventilators, and we have been doing a lot of awareness camps for the community, for children, for parents in the schools, because we have a younger route tract group as well as the schools. So this is what we have been doing. And I would very much like Association of Medical Consultants, and I'm since in the central position on both, one side there's AMC, other side is Rotary. I'd very much like to get associated with AMC, because I think the age is now of collaboration. It is no longer of individual work. All of us, we have our own capacities. AMC has enormous capacity. Rotary has enormous capacity. I'm sure Lions and other NGOs, and especially BMC and Government of Maharashtra, they have enormous capacity. It stands to reason that if we have to tackle community and we have to tackle this pandemic and we have to address this pandemic successfully, then all these organizations must come together and work. We have undoubtedly, we have numerous outlets, and we will be able to help us throughout. Now AMC has 13,000 members. Rotary also has 13,000 members across Mumbai, suburban Mumbai, Dombivli, Thane. So we are on par with AMC. AMC is doing tremendous work for medical and medical related issues. And I'm sure in pandemic, both of us can come together and really work very hard to see that the end of the pandemic.
Yeah, thank you so much, sir. It's really heartening to know, and of course, the image of Rotary is one that is always comes in the forefront of helping the general public, and I'm sure it will continue. So our next question is to Dr. Tanu Shinghal. Recently, there were news about Mr. Boris Johnson, the UK Prime Minister, addressing the House of Commons, and where he said that UK is lifting all the bans, so no masking, so people can come back to offices. So can this be replicated in India? If yes, how soon can we see that?
Thank you. I would first like to thank AMC for inviting me here. So at the outset, I would like to say that, this is a very country-specific disease. So every country will follow different precautions based on the epidemiology and also the health infrastructure they have, the vaccination, the booster vaccines, etc. So UK, as per its data, has decided that, maybe it's time to lift the restrictions. Now, having said that, even if we cannot have a uniform policy for India, because you know that the epidemic follows different phase, like for instance, Maharashtra had its peak, or Mumbai had its peak, and now Karnataka is having its peak. So every state will have to have its own policy, and in the state also every city will have to be different. So specifically talking about Mumbai, I can say that we are at the waning edge of the epidemic, and luckily, even when we were at its peak, there were not too many restrictions which were imposed, because it was realized that cases were mild. So we didn't have local trains stopped, we didn't have shops closed down, we only had some restriction on gatherings, which was actually a very, very good thing, because otherwise there would have been a lot of collateral damage in terms of people losing livelihoods and economic disruption, etc. So in that way, really, Mumbai never even locked down in the third wave. So now that we know also from past experience that once a wave goes away, then the next wave takes some time to come. So you actually have some time between the two waves, which we should utilize to our advantage. So it would be good that, now the task force would take some decisions about unmasking in open spaces, and also about opening up other things fully. Schools are being opened, which is actually a good thing. And to reply to what was said earlier by Dr. Jahangir about vaccination of school children. So we know that children have mild COVID disease, and therefore vaccination of children is not a prerequisite to opening up of schools. Provided the elderly people and the adults in the house are vaccinated, children can resume school. And because it's not that children are not going elsewhere, they are going everywhere. They're going out, they're playing, they're going to shopping areas, and the adults in the family are going out. And children have been infected despite the fact that for 2 years, schools have been closed. So now is the time that we should open schools uninterruptedly, and like other countries where really schools were never closed. So I would say that now is the time in Mumbai at least to try and ease some restrictions even further and make sure that schools remain open so that disruption is less.
Okay, thank you. Thank you so much, Dr. Danu, for your guidance. Vikram? Okay, can we ask?
Vikram is muted.
Sorry, can we ask Dr. Ravindra Kembabi if he has anything to add on this? You're muted, sir. Can you please unmute your mic, Dr. Kembabi?
I think so. BMC has taken right decision. Initially, it was planning to start the vaccination, but you know that many studies have done. It shows that the studies show that more than 52% of the children have already affected have antibodies. But what happened initially, the BMC was starting it, but then Omicron came and the infectious was very high. And secondly, children should be made aware of some preventive measures. See, adults are not following the guidelines of wearing masks, sanitization, and children are one who are more contact, more unhygienic, and they play each other, and they don't know how to wear the mask, and they put the mask. I myself have given health education to all the school children of BMC. That is virtual on the this, not to this. Many questions have mind in the children of when the school will start, what will happen, and all that. But very important that awareness of COVID appropriate behavior to be practiced by children is a one difficult task. And this Omicron, when it came, initially BMC was starting, but Omicron came in, and we felt that children will not be able to practice, and the infectiousness will increase the cases of children, and the hospitalization may be more. And that is what I think government had taken right decision of not starting the school. My personal opinion is that awareness for appropriate here should be in the children. And secondly, children, the antibodies are already with them, but the diseases like Suhas Prabhu has already showed MIS, which children's parents and school children should observe it. And if there are any cases, immediately report it and then can pivot. And opening of the schools should be very cautiously done. And vaccination will, as we know that the Prime Minister told us that about 12 also vaccination will start by the March and all that. And I think so slowly it should progress. High adults in 15 to 18 should be vaccinated. It is told that these are the young adolescent children who have been infected, but they get infected, and but the adults who are affected, which was seeing that many adults died because they did not came out, but the young child who roam out here and got the infection. So vaccination should start one and all, and children's also vaccination should be given as early as possible when the trials are there and the results are there. But vaccination should be given high risk group, and that's the right decision which has taken by the government, giving adults first and then the comorbid people, and now 15 to 18 years group. And slowly the vaccination will progress depending upon the epidemiological trends. The vaccination should be decided, and school be accordingly. The task force will decide when to start the school, and it should be very rational. It should be cautious before starting. Health education, awareness, COVID appropriate should be done, because we don't know which variant will come and which will be affected. For example, early smallpox, malaria, there was it was affected the children's very much high. But now we are thankful to COVID that it affects adults more, not the children. If children were affected, then it would have havoc. So it's very important that we should reduce step by step.
Thank you so much. So one more question that is connected with the vaccine is, which I would like to ask you, and also ask Dr. Tanu Singhal or Suhas Prabhu sir to comment, whether the COVID vaccine will be included in the government's immunization schedule going forward, and also by organizations like the IAP. So what are your thoughts on that?
About the vaccination of children, yes. It's a big question, but it is, already there are already children have antibodies and all that. Main important is giving primary vaccination should be decided when to give, how to give, and this is the task force should decide about it. But nevertheless, as children have mild infection, and slowly we should go step by step, high risk group, then all, because vaccine is very costly, and it's very important each and every adult or above 60 years and high risk group should be given first, and then the low risk. So that should be the prioritized way.
So I would like to say, yeah, so we really don't know whether, hello? Yeah.
Yes, we can hear you.
Yeah. So as I said, we really don't know how long COVID is going to be around. So it is very difficult to say whether this is going to be made part of the vaccination schedule or not. So right now we'll have to play it by the ear and see how the epidemiology of the disease progresses. Because there is one school of thought that, the disease, the pandemic may be over, COVID may remain as an endemic infection, in which case the people who are highly vulnerable are the ones who will need annual vaccination. So it is too early to say whether we are going to have regular vaccination against COVID for children and adults, and we'll have to see as time passes and how effective the vaccines will continue to be against the new variants which will come up. So whether there'll be a need for it and whether the vaccines will remain to be effective, something time will tell.
Okay. Thank you so much, ma'am.
The next question is to Mr. Jahangir Gai. How responsibly has the general public behaved and complied with respect to the lockdown and the restrictions?
I would like to put it the other way. How responsibly have the authorities behaved?
Sir, that is the next question, sir. What are the deficiencies that the public felt that from the administration side?
When you keep a lockdown and release the people only 2 hours a day, they rush out like a herd of cattle going to pasture. So what happens? Instead of distancing, there is more herding. And despite this, we have been able to considerably control and overcome COVID and come out without much loss. I think only herd immunization is the best response. We may talk theoretically about various things opening up. Today, it is our experience. If a person wears a mask, his voice gets muffled. When the voice is muffled, in courts, the hearings get affected. In classrooms, even the people on the second bench cannot hear a teacher. So unless you open up and lead a normal life and allow herd mentality to set in, I don't think there is any other solution. People are cooperating, more people are dying, not because of COVID. COVID may happen, may not happen. You may get well, you may not get well, 25% chance. But loss of livelihood is the greatest toll which people are suffering. The common man is really suffering more because of the repercussions of the way and the way in which this pandemic has been handled.
So am I right in assuming that we need herd mentality to achieve herd immunity?
May I tell it? Because see, the COVID vaccine, this disease was a new one, and I think so. We are human beings are war with the COVID virus. COVID virus is very smart and it makes its own moves. It replicates many times in favorable condition, and many variants have been generated. Human being initially had no knowledge about it, how it is spreading and all that. And we were beating on the bush. We did not know exact treatment. Many people are affected. Many adults were died. But we are lucky that it affected the adults, not in the children. The only measures the government had at that time was lockdown. That was the only solution to reduce the risk. That government has done as early as it came to know. And other thing is that we have got limited measures which health workers have done. Previously, you had no antiviral drugs, no oxygen supply, and secondly, only limited measures, masks, social distancing, and even we had no vaccination. But now, 2 years on, we are now aware, and I think so. Previously, people were very late to wear masks. Masks were not available. Masks were sold at double rate and all that, and which is not in a common reach with the people. And that is very important. Now, the awareness in people has increased. I've seen myself that people of Mumbai are wearing masks and they are doing it. See, it affects when you are affected. The people who are affected, their elder people are affected and all that, they follow the procedure. But those who are not affected feel that why I should wear, I am not affected. I roam about without mask. So many, they give their examples themselves that I visited here, there, but I have not suffered. I have got immunity. That's not so. Unless until everybody, the awareness should be spread among the people who are affected, make a role model saying that this has affected my family. I should see that each and everybody wears the mask. Awareness should be there. And that has gradually fit. I see many people wearing the mask in trains and all that. And the good sign, people are cooperation and they are ensuring. And we can't force any rules and regulations because India is a democratic country. Each and every people have to decide for themselves how to protect themselves and for the others. This is my.
I would like to say something here. So some amount of mask fatigue is also setting in amongst people. I mean, you know, it's been 2 years. And if you actually say that people are wearing masks, but none of them are really wearing masks appropriately when they're going, it is just a kind of, you know, it is like just it's for namesake that you're wearing a mask, but people are taking their mask off all the time. And we don't even know that this kind of haphazard masking, is it really going to be useful? Even if you audit 100 people on the road, you'll find that 95 have a mask, but it is below them. So also we have to think that how long can this masking go on? Should there be a period of relaxation when the number of cases are down and people are vaccinated between one and the next wave? Because this mask fatigue is also setting in. And we have to, think of that as well. Maybe in enclosed spaces, yes, but in open spaces, whether we should continue to use masks is also something that we need to dwell think about?
One thing about it, I will say about the COVID virus, the mode of transmission, droplet and airborne. The government and WHO was reluctant to comment that it is airborne infection. Airborne infection COVID is one in which the virus stays in the air for some time. And secondly, the fomites which are there liberated are also where they settle, road knobs, the cardboards, the papers, they also the virus is there in them. And the people who handle that get infected. And thus such awareness should be awareness about wearing mask and how to wear the mask. Many people they wear cloth masks, but once they wear it in the front side, they wear it opposite, they get infected. So awareness, government should create awareness. Initially, there was no awareness done by government. Everywhere using their own handkerchief or something like their whatever available for their protection, and the masks were so costly. And the Supreme Court had to come to reduce the mask. N95 was 1,000. So I feel that government in an epidemic stage, the rules and regulations should be uniform and each and every should follow that. And usually the person who produces and sells should have, the government should have control over them. Even drugs, even oxygen was sold in black. The antiviral drug were 3 times in many other states have been. So on the large public was affected and there was no action by the government against. They had taken action, but that is too late. So very important is in that patient, it may be 100% and they will be very troubled and they will be very frustrated. So I feel that awareness should go on till there. We don't know what variant will come. And I feel there are 3 scenarios. I myself have done about 3 scenarios which are there, which is there. One scenario is that now we have got Omicron, which is there, which is very good. It is spreading. Only upper respiratory is affected. Lower respiratory are spared. More people are infected. Antibodies are created. Also, studies recently has shown that antibodies are created. Neutralizing is there. Even Delta is there. Soon, I hope so. This because antibodies are created in all variants. This may end soon, but vaccination and the pros and cons is vaccination is not done. There are many people who are still not vaccinated. It is a big which are there, and it is in pockets. There are many pockets which are vaccinated, and there are many antivirus lobbies. They say that I have taken vaccine, but I got suffered. What I should do? I have taken the vaccine. I have died. This misconception among the people, this awareness, what is the effect of vaccine should be generated, and this the lobby which is against vaccine should be educated and be sure that this is one thing which is happening all over the world, not over India. Even anti-vaccinators are there in US, UK also. But India, I feel they are less anti-vaccine, and this is a good thing for us. It is there. This is a good scenario. Second scenario is that in the variant which is there, which may be slightly more severe. It may go on spreading and see, all the pockets are not immunized. Variant changes, one pocket is affected, another pockets are affected, and then it may go like seasonal flu, it may become endemic. Third scenario is there in which the virus becomes like Delta virus. It mutates and more cases are happening and all that. We can't say what will happen the next. We have to be, and there may be Delta virus. If Delta virus would have been there, there should be more hospital admission, more deaths, and more havoc could have been happened. But that is, we are lucky it is not there. But nevertheless, we have to prepare for the worst whenever it is there. So for that, my suggestion is that government should follow following features which are very important. Is that the COVID itself has taught many lessons to us. One is lockdown. The environment pollution has been controlled. Importance of cleanliness and hygiene is highlighted. There is reduced gastrointestinal infections. Roadside littering is stopped. Importance social distancing in immunity. And second is tuberculosis has reduced because people are wearing masks, not spitting here and there. And government should, I feel, invest in strengthening the health infrastructure. See, when the cases were increasing, beds were not available, but the infrastructure was not there. Even the facilities in the existing hospitals were not up to the mark, which is there in other countries. The increase in primary healthcare physicians, increase in the number of nurses, pharmacists, and medical assistants. There should be an investment in novel treatments, vaccine development, pathogen sequencing, outbreak investigations should be carried out, which is, I think so, it is not up to and the research supporting emerging infections. Now 2 years are there, but not a single research from India has been published again the contact tracing or the number of people affected. See, this awareness, these researchers will give what is the scenario in India, and that will help us. Now, few research has come that reinfection is very less, and secondly, the vaccinated people. This, if it is come, the people will think the vaccinated people, unvaccinated are dying, so we get well vaccinated. So research should be a priority of the government, and investing in importance of import of airborne infection. So airborne infection are very dangerous. This is there when I was telling in when SARS epidemic was there, SARS COVID was there, where it was there. I told that one person who lands in Virar local, where it is so crowded, how many people will spread? The same scenario has happened now because of COVID-19, and it has created the havoc. The awareness in the people about cleanliness, hygiene, nutrition, diet should be done. And lastly, very important is that the Epidemic Act should be strictly followed, that nobody should be allowed to flout regulatory measures declared to control epidemic. Rumor mongers should be punished, should be strictly punished or taken into confidence and should be changed. Black marketing should be strictly punished. Who are selling drugs at double the rate, masks at double the rate. Strict control over essential drugs should be also be done by the government. So even the mask and sanitizer is sold at many double rate. First, I feel that the briefing, the clinicians and the experts should brief the politicians leaders should be done so that no wrong message is sent, because many wrong messages spread. See,
Dr. Kimbab, I'm sorry to interrupt you.
The ounce of prevention is better than cure. The government should stress on more prevention than cure. Means prevention should be given more priority. Cure is there, that should be going on. So this is about my summation of the vision. Thank you.
Thank you so much. Thank you so much. The next question is, since as you said that COVID has taught us a lot of lessons. Of course, our vaccination has ensured that the Omicron strain is not causing that severe illness. So my question to the panel is also that do we see new variants coming on the horizon? And do you think our mass vaccination or the vaccination that is currently going on to cover the entire population, will it help to reduce the emergence of new strains and more virulent strains? Dr. Singhal, please.
So recently there have been a lot of messages and articles in lay media about new variants. So one which came up just 2 days ago was about some neo-CoV, which came, from bats in South Africa, had this very dangerous virus, which would cause 33% mortality if it crossed over to humans. But that is actually just a hypothesis, and this virus has not yet crossed over into humans. So we don't need to worry about it, as so far it's not a SARS-CoV-2. Then people were talking about Florona, which is nothing but flu and COVID combined. Then Delta Micron, which is again not a variant. Similarly, there was a talk about IHU, which was discovered in France. But again, that is not spread widely. So we don't need to be unduly worried about these reports which keep coming in. And so far, apart from Omicron, there is no new variant of interest or variant under monitoring. But it is possible that they may come later. But when will they come, and if they will come, we don't know. So far, we have also understood that whatever vaccines have been made against the original virus. And while they have not really protected people from infection, like with Omicron, they have actually protected people from severe disease and hospitalization. So we should continue to vaccinate with the currently available vaccines, where we should focus to make sure that everybody receives their 2 primary doses, and then the vulnerable people receive their boosters. And it is quite likely that some protection will be offered by these vaccines, even against future variants.
Madam, one more question is that Omicron infection is giving, reasonable amount of immunity. So should the precautionary or the third booster dose be taken? What is your view about that?
So far there is very little data about this. There is data from an ICMR study which showed that people who had been vaccinated and had got Omicron infection, their sera was able to cross protect against other variants. So it is not so, but people who have had infection with Omicron should delay their booster by 3 months, because this will give them at least immunity for 3 months. And it's possible that after 3 months, you may have a better booster available. You don't know, Corbevax or Novavax may come in, or the mRNA vaccines may become available. However, people who have not had Omicron infection in the current surge, they've not tested positive for it, they should actually go ahead and take their booster vaccine. So those who took Covishield should go ahead and take Covishield. Those who took Covaxin should go ahead and take Covaxin. But those people who have been infected should delay their boosters by 3 months.
I would like to ask Dr. Balkrishna Inamdar, sir, with Rotary, they do a lot of projects. Is there any project going on for public who are suffering from long COVID symptoms?
There are many medical projects which are going on. But if you are talking about the post-COVID syndrome,
yes,
so far we are not gone into that, because we still believe that the medical fraternity is the best fraternity to look into this. But we are open to this. What we are into is vaccination, and now we are looking at something called a sero survey. I think it's high time that we should do this sero survey of communities. Take sample communities across Mumbai, for example, find out which area has higher immunity, herd immunity compared to the other one, and concentrate vaccinations in the areas where there are less seroconversions. So this is something which we are now seriously looking at, and we are also looking at the mental health, which is coming up very fast. Apart from that, support for the mucor infection, and these are some of the things which we are looking at. As far as the awareness is concerned, I think it's high time that we should stop looking at absolute numbers and only concentrate on percentages. Let me give an example. If there are 100 people getting COVID infected, and obviously the efficacy of any COVID variant, any strain depends on the death which occurs out of that strain. So if there are 10 people who are died, then we must realize that out of these 100, 10 are non-vaccinated and 90 are vaccinated as per Dr. Gomare's incidence. So out of 90, if 5 are dead, and out of 10, if 5 are dead, then what we are looking at is a 50% death rate in the non-vaccinated, while just 5 to 6% death rate in the vaccinated. Now, this is a very important percentage which we need to go across. While we have to realize that every person has a right to decide whether he should get vaccine or not. Organizations like yours and mine, we have a right to convince them to get vaccinated. That is also there. So we should try to concentrate only on percentages rather than absolute numbers. And having said that, we would love to be part of any AMC drive on this. As I said, there are the few areas which we are looking at, and these are the important areas while we are looking at to end the pandemic, like sero surveys and the mental health and the post-COVID syndrome. And we would be part of that.
I just want to make one comment that because of COVID, attention to other illnesses has declined a lot. Yeah. And therefore, more people are dying because of other illnesses which have not been treated properly as compared to COVID, especially in the current Omicron era. And, because of this policy of testing people who are admitted to the hospital for any reason for COVID, many people who have incidental COVID also are not getting proper care. So we have to start focusing on these things. And kind of move away a little bit of attention from COVID and look at other things, and maybe modify our policies and protocols for so many things like use of PPE, testing, and all these things in the current wave, because a lot of damage is happening for other diseases.
I just would like to add one thing into this. What Tanu madam has brought to notice, that it is really very important. Because as in public health, we are seeing that the births and the deaths happening in city of Mumbai, that ratio has really changed a lot. in 2020, it was a year of COVID, and we have seen a lot more deaths of non-COVID causes also. So we have to look into that. Even in 2021, we have a lot more deaths as compared to pre-COVID era. So we have to really look into that, why these deaths are happening. They are not COVID, but non-COVID deaths are happening more. So though this COVID is going to be there, and we have to be with COVID, but then also non-COVID patients and non-COVID activities also we have to prioritize and look into that. Just I would like to give an example that in 2020 we had around 1,20,000 deaths reported in city of Mumbai, which is very more compared to pre-COVID era, where we usually report around 90,000 to 95,000 deaths in city of Mumbai. And then in 2021 also we have reported more than 1 lakh deaths, not only to the COVID, but many of them are attributable to the non-COVID causes. So this is really very important now. After passing 2 years in COVID, we have to look into all those non-COVID reasons and patients, and we really need to prioritize them. Thank you.
So moderators, can I make a comment here?
Yeah, please go ahead, ma'am.
The healthcare system and the infrastructure needs to be strengthened. We all know that for a long time. And this COVID has actually, crystallized the whole thing, that yes, we have deficiencies in our system, and huge deficiencies. It's not just, if we are able to manage one aspect, we are not able to manage another. And whether patients are dying of COVID or non-COVID causes, ultimately it affects the total overall mortality, and the management of these patients is at the crux of the health department, not just individual medical professionals. So can we not have, now this is an open question, and it is a thought which has just come to my mind, that like how we have for COVID, we had created a central portal through which patients were getting admitted in whichever area was available. Can we not have that for even the non-COVID? Because non-COVID were just left on their own. I think we can create such a system, and we have a robust system where the public, private, all healthcare systems are in one place, and they are working like a team, not like individuals who are left on their own, and public health systems who are overloaded with patients already in each aspect, in non-COVID as well as the COVID care.
I think Dr. Nandini Kumar wants to make a comment. Dr. Nandini?
I have 2 points. One thing is, which was being discussed over and over again, about the importance of maintaining public health. In such situations, individual rights actually get overridden by the the public health practices and the policies. So that is the only way out. But then in India, we are taking a softer stand, in the sense that public is still given a freedom to make the choice. So in such situations, only awareness programs will actually encourage people to seek what the government wants to do. And the other thing is, I think Dr. Mangala's statement about non-COVID situation is very important. This was highlighted over and over again, that the deaths due to non-COVID, I had a slide, I didn't put it there. Non-COVID deaths are much higher than the COVID deaths. COVID deaths have taken the attention of everyone because of the deaths that have happened and tragedies that have happened. But the other tragedies, people dying because medications have not reached them, from the other chronic diseases which need to be controlled, are actually thrown to the background. So the government actually is trying to now have similar portals that was talked about, like NACO has for HIV. So whatever organizations are concerned with this, they are also thinking on those lines now. Thank you.
Yes, Dr. Inamdar, please.
Yes, we should not forget the role of media here. I think it's very important that when we are talking about awareness, and let me go back to the example that I gave, where 5 deaths in non-vaccinated and 5 deaths in vaccinated. A media headline can be deaths in vaccinated and non-vaccinated are same, that is 5 each. Now, instead of that, we must make them aware that it's a percentages wise we need to give, and awareness for vaccination is very crucial. And that if together we can come out with a statement along with the government, along with BMC, I think that would go a long, long way if we also consider media to be part of this awareness.
To add to what Dr. Val was saying, like we had a news coming out that COVID causes severe disease in children. And, there was some quote from Calcutta saying that, these children died of encephalitis. Now, such a news item can really cause furore amongst parents. And this is an isolated incident. So I mean, I think there has to be some kind of media responsibility too while reporting things. There was one statement which was made that if a third wave happens, it will affect children more. And that had really caused so much of panic all over the country. So I think it's really important that the media also plays a responsible part and tries to put matters in the proper perspective.
There is one more point which I wanted to raise is about testing before. Like many people have not tested. In January itself, many people have got upper respiratory tract symptoms. While so many have tested, so many have not tested. So many places, every household, there were people who were having URTI symptoms, but not everyone has got tested. Now, when we are talking of precautionary dose and the duration of 3 months, which needs to be maintained, now all those who have had URTI, should they be tested before they go in for the booster dose?
No, they should not be. So basically, suppose they were, because now how would you test them? That if you do an antibody test, it will not tell you about the level of protection they have, because people who had antibodies also got COVID. And you can't test them for the PCR because it is too late now and they will be PCR negative. So I think if the certainty of having COVID is very high, like for example, there were multiple people in the family who were affected at the same time and one person was COVID positive. In that situation, you can reasonably assume that you had COVID and you could delay your booster by 3 months. On the other hand, if none of the family members had tested and you don't have a documented case of COVID in the family, they should go ahead and take their boosters. Because we must remember that taking a booster earlier than 3 months is not going to cause any harm, but it is actually not required. And it will reduce the total cumulative immunity that you have against COVID. Because let's say the vaccine gives you 6 months immunity. So if you delay it by 3 months, you get 9 months protection. That is hypothetically speaking. Whereas if you've got the infection and you take the booster immediately, you get only 6 months immunity. So that is the reason why the government says you delay it. And also because there's a shortage of vaccine and people who really need it are the ones who should get it. So this is a kind of answer to that situation for people, who didn't test themselves, but who probably had COVID.
So it does not cause harm, even if it is taken less than 3 months, is a good sign, and that should be taken positively, because there have been views about people if that COVID vaccination could cause some harm when it is, during that period, less than 3 months. So that's great. Thank you so much for clarifying.
So I think in the interest of time, can we close the panel discussion, because we have already crossed our time limit, and our panelists have been very patient, bearing with us and being with us all this time.
Kayum, we can take one take-home message from each of the panelists.
Yes, I was about to say that. Yes, thank you, Vikram. So can we ask each of our panelists to please give us a take-home message? We start with Dr. Singhal, please.
So I think COVID is here to stay for some time at least, and we have to learn to live with the virus. We have to make it, take it as a part of our life and move on. We have to move on. And we have to balance the precautions versus the opening up. And I feel that school opening is a priority here. Completing the 2 doses of vaccine for people who have not been vaccinated is the priority at this point in time.
Yeah.
Mr. Gai? Yeah.
I totally agree with Dr. Tanu Singhal.
So your take-home message, sir.
Well, it's the same thing. I would repeat it. All that I would say is that we have to learn to live with this, treat it like a flu, forget social ostracism, because the sort of quarantine centers which were developed created more panic. And the media fueled that panic much more. So we have to have a responsible media. We have to see that proper information is disseminated so that it doesn't fuel fears among the public.
Absolutely. Yes. Thank you so much.
Dr. Gomre agrees with
Yeah,
this?
yeah, yeah.
I am not sure.
Yeah, I am there.
Yeah, yeah. Okay. Thank you, madam.
Do you agree
Thank
with
you.
this?
Yeah, I agree. And I also reiterate the same thing, that COVID is going to be there for years together. We don't know in which form it will come. Like Omicron, if it comes, it will be beneficial for us, but then maybe in a different format, which will be detrimental to us also. So we'll have to really follow all the COVID appropriate behaviors. And yes, we have a good weapon with us, vaccination. So please, I will appeal all the citizens to get vaccinated. And whenever precaution dose or booster doses are coming in, we'll have to take that. And another very important thing is that all the time we just cannot keep on using masks months together or years together. So we'll have to be very careful in whenever we are going into social gatherings, get-togethers, and family functions. We'll have to take care. That is very important now. Thank you.
Thank you so much, madam. Yes, Mr. Dr. Inamdar, your comment, please.
Yeah, I also believe that COVID, even if it's not pandemic, it will be endemic, as we know the history of all such infections in the past. So it will be of an endemic for a number of years. So in these cases, it's important that the complications of COVID, the post-COVID, long COVID, as we say, they have to be tackled properly. But very, very important probably is all the organizations coming together. Maybe we can have a central organization where everybody is involved. And that central organization can then take care of all aspects of COVID support for the community, all aspects, whether it is a facilitation, whether it is awareness, whether it is a vaccination, whether it is a surveys which we have to do, whether creating white papers on different researches if we have to do. There's nothing wrong in also looking at research for this COVID on our own. So I would very much like to have a central organizational structure where a number of organizations come together and then we take a combined decision for the communities.
Thank you so much, Dr. Inamdar. Dr. Sushmita, our president, would you like to give us a final comment and then we close this discussion and the meeting?
I am very happy to hear all the comments or the take-home messages of all our panelists, because we are just waiting to celebrate our Golden Jubilee celebrations with a bang and not in an online mode. So yes. I'm just so happy, and I wanted Dr. Gomre to emphasize that yes, we will need to take precautions, yes, but madam, we'll need it on paper. We'll need it in writing that all the bans have been lifted and that we will be able to celebrate.
I wish you can have a big celebration, and I also could join that.
Of course, you will be a part of
it.
Sure,
you have to be a part of it. Thank you so much, everyone.
Yes, thank you.
Thank you,
and all the best to AMC.
Yeah. Vikram?
Yes,
hello. Yes,
yeah.
Please go ahead.
Gomre madam, this is a small appreciation from our side, the memento and the e-certificate. Please accept it.
Yeah, thank you.
Mr. Jehangir Gai, this is from our side to you for your very frank and honest opinions.
Thanks a lot.
Thank you so much. Nice to have you. Dr. Tanu Singhal, it is a pleasure to have you with us and hear your opinions and comments. Really, they were really useful. So please accept a token of our appreciation in the form of a certificate and also a memento. Thank you so much, and we look forward to working with you closely in the near future. Thank you so much. Dr. Balkrishna Inamdar, we wish to thank you. Thanks a lot for all the efforts that Rotary has taken, working closely with the medical fraternity and as organizations to create awareness and to help the lay people, the population at large. So as a token of our appreciation for your participation and your presence today in our panel discussion, please accept this certificate and a memento as a token of our appreciation. Thank you so much. We really thank all our panelists for their time, the patience, and their active participation in the panel discussion. Thank you so much.
Thank you. It was a pleasure for me to be with AMC.
Thanks, sir.
Also, special thanks to Dr. Khembavi for staying back after his talk and being a part of our panel discussion and giving his valuable inputs.
Thank you, sir.
I would like to award a certificate appreciation to our moderators, Dr. Vikram Khanna.
Thank
and
you.
A memento on behalf of AMC, and also to Dr. Qayyum Muqaddam.
Thank you so much. It was a
for
pleasure.
moderating this session very well, and the panel discussion to a great thing.
Thank you.
On behalf of AMC, I would like to thank all our speakers, Dr. Rahul Pandit, Dr. Suhas Prabhu, Dr. Nandini Kumar, Dr. Ravindra Khembavi, the panelists, Dr. Mangla Ghumre, Mr. Jahangir Gai, Dr. Bal Inamdar, and Dr. Tanu Singhal for such an excellent COVID-2 update for all our members. Thank you very, very much. We had a huge participation of around more than 550 live on the Zoom webinar, plus more than around 150 on the YouTube channel itself. Okay, we'd also like to thank our President Ma'am for organizing such a wonderful seminar. Okay, and our program committee chairman, Dr. Vikrant Desai, who had to leave for some work. And also to our team partner, Mr.
I am there, sir. I am there.
We are there. Okay, welcome back. And also to our partner, our technical partner, Mr. Finovate, for managing the whole show. Thank you very much.
Thank you so much.
Stay safe.
Thank you. Team
Hope to see you
AMC
at
Zindabad.
Thank
AMCON.
you.
Yes.
Thank you, Dr. Jayesh, for being the very wonderful host.
Oh, thank you so much. Thank you, everyone. Thank you for the opportunity, President Ma'am.
Thank you.
Okay, please stay safe, everyone.
All of you, please take care.
All of you, yes, same here. Take care.
Wish for the happy times. More to come.
Yes.
Thank you.
Thank you, everybody.
Goodbye. Goodbye.
Thank you all.
Bye. See
Rohit,
you all
you may end the
again
meeting now.
soon. Yes.